We are live now. I'm sharing my screen. Good evening, everybody. This is Piyush Shukla from Corona Remedies. Welcomes you all in Happy Learning Masterclass webinar series, edition number 152. Theme Mixed Bag. Moving forward to MOC for today's program is Dr. Suman Sinha and Dr. Asha Jain. Dr. Suman Sinha, President Ranchi OB/GYN Society, Senior Consultant at HAAH IVF and for Infertility Center Ranchi, Director Advanced Care and Maternity Center Ranchi. A very warm welcome, ma'am. Dr. Asha Jain, Director SMSA Hospital Raipur, Medical Director Cancer Prevention and Relief Society, elected member Chhattisgarh Medical Council, Vice President IMA Chhattisgarh, and has more than 32 years of experience. A very warm welcome, ma'am. Coordinators for today's program are Dr. B. Kalpana and Dr. Jyoti Banglowala. Dr. B. Kalpana, Course Director for Postdoctoral Fellowship in Endogynecology, affiliated to MGR Medical University, National Coordinator, Infertility Committee, FOXI, Chairperson, Infertility Committee, TNFOG, Secretary, MOGS. A very warm welcome, ma'am. Dr. Jyoti Banglowala has 26 years of experience, Vice President, Indore OB/GYN Society 2022 till present, Senior Secretary, Indore OB/GYN Society 2021-2022. A very warm welcome, ma'am. And as per the tradition goes, I'd like to start the program with lamp lighting ceremony. Again, a very warm welcome to everybody, those who are attending the program and those who are seeing. Moving forward, I'd like to hand over the session to Dr. Suman Sinha and Dr. Asha Jain. Ma'am, please.
Thank you, Mr. Piyush. Am I audible?
Yes, ma'am.
Okay. Good evening, everybody. After invoking blessings from our deities, we move on to the inaugural function of our program. I, along with Dr. Asha Jain, MOC Happy Learning, take the pleasure to welcome the dignitaries and our esteemed guests in the 152nd episode of Happy Learning Masterclass webinar series in association with Chandrapur, Bhandara, and Nagpur OB/GYN societies. As we all know, Happy Learning is the most apt platform for sharing and enriching knowledge. And for this, we are extremely indebted to our program director, a medical legal expert, ex-Vice President, FOXI, Dr. M.C. Patel, sir. His vision and strong commitment has brought us to the 152nd episode. It has been an incredible journey. All applause for him. And now, at the very onset, I welcome our Honorable Chief Guest, Dr. Silva Joshi, Madam, our revered guest of honor, Dr. Rajlakshmi Sardas, Madam, and Dr. Rajlakshmi Srikhande, Madam. I welcome our convener, Dr. Sneha Vihar, Madam, our luminary speakers, moderators, chairpersons, and panelists for accepting our invitation and very meticulously preparing the subjects to upgrade us. I welcome all the coordinators, Dr. Jyoti Banglowala, Dr. Kalpana, for their support. I welcome all the delegates, presidents, and secretaries of all societies who have joined us today. And I welcome our academic partners from Corona for the digital platform. Now I invite our program director, Dr. M.C. Patel, sir, for the official welcome address.
Thank you, Suman. It gives me immense pleasure to welcome you all on 152nd episode of Happy Learning Masterclass web series, and joining society Bhandara, Chandrapur, and Nagpur I invite all of them. I welcome Dr. Sulbha Joshi Madam, who have kindly consented to be chief guest to bless the webinar. So I welcome Dr. Sulbha Joshi Madam. I also welcome Dr. Raj Lakshmi Madam from Chandrapur. She has kindly consented to be guest of honor to bless this webinar. And one more guest of honor, Dr. Lakshmi Sikhande Madam from Nagpur, who is chairperson ICOG. She has also kindly consented to be guest of honor to bless the webinar. I also welcome two learned speakers who are going to deliver very important talk for today's webinar, Dr. Shivangi Jagirdar and Dr. Meera Agawale. They are going to discuss very important subject. Shivangi is going to discuss Lochai hormone in infertility, and Meera is going to discuss first trimester anomaly scan. And now concept is getting changed from second trimester to be shifted to first trimester scanning and to pick up anomalies early and to manage patient accordingly. It is expected from law also, as early as you can, if you can pick up the situation and you can manage accordingly, then you could be out of problem. I also welcome two learned moderator, Dr. Sushma Deshmukh Madam from Nagpur and Dr. Manisha Ghate from Chandrapur. They are going to discuss very important panel. They are going to moderate this panel today. Stimulation protocol of IUI. IUI is a very common procedure. So many of our friends are practicing in their day-to-day practice. And now how to stimulate patient for IUI is the today's topic for panel discussion. I also welcome two expert panelists. They are going to put their expert points and comments during panel discussion. Dr. Sneha Buyar and Dr. Rekha Rajendra Kumar. Rekha Rajendra Kumar from Bengaluru, Sneha from Dr. Sneha from Yavatmal. I also welcome all the learned panelists, Dr. Bharti Rajsekhar from Hassan, Dr. Prajakta Aswar from Chandrapur, Dr. Manisha Vasade from Chandrapur, Dr. Manoj from Bandara, Dr. Minal Bure Madam from Bandara, Dr. Anjali Nange Dhote Madam from Nagpur, Dr. Minal Madam from Nagpur, Dr. Chaitanya Sembekar from Nagpur, and Dr. Sarmili Podar from Chandrapur. I also welcome all the chairperson who have kindly consented to chair respective session. Dr. Pragati Khalatkar from Nagpur, Dr. Priya Sinde from Chandrapur, Dr. Anuradha Ridodkar from Nagpur, Dr. Bharat Lanjevar sir from Bandara, Dr. Kalpana Gulwade Madam from Chandrapur, Dr. Vaidehi Marathe from Nagpur, Dr. Sweta Manvantkar from Chandrapur, Dr. Varsa Dhavle Madam from Nagpur, and Dr. Sarla Agarwal Madam from Nagpur. I also welcome both convener, Dr. Sneha Buyar for this webinar, and two learned coordinator, Dr. B. Kalpana from Madurai and Dr. Jyoti Banglowala from Indore. And of course, two master of ceremony, Dr. Asha Jain from Raipur and Suman Sinha from Ranchi. So this is our team, Dr. Sneha, Dr. B. Kalpana, Dr. Jyoti Banglowala, Dr. Asha and Dr. Suman Sinha. And they are since long in this series and they are doing marvelous work as far as Happy Learning Masterclass web series is concerned. And of course, all the fronts as far as any activity of Foxy is concerned. So I welcome all of you and all the societies who have joined this society, president and secretary of respective society and all the delegates. So in era of COVID-19 where physical meetings were not possible, we started this series to meet our Foxian friends and to say hello and to discuss some focused topic. And its goal was to be helpful to our Foxian friends and ultimate to be helpful to our patient. But today we have selected a very interesting topic related to infertility, and we are going to discuss respective topic for today's webinar. So with this short remarks and welcoming you all again, over to you, Dr. Suman, for further proceeding. Thank you very much.
Thank you, sir, for the lovely welcome to our dignitaries. And now I request Dr. Asha Jain to introduce our convener, Dr. Sneha Buyar.
Namaskar, everyone. And Dr. Sneha is not here. So I think we will have her.
CV.
You can introduce her in brief, and when she joins, we will have word from her at that time. No issue.
Okay. So everyone knows Dr. Sneha, who was the Foxy Breast Committee Chair and Governing Council member of ICOG, CEPOC Working Committee member. She is also the AMOGS Chair, Medical Disorders Committee 22 to 24. And she is an excellent teacher, very academic and very sincere in her work. She is standing for Vice President Foxy this year. So she is also the convener of this program. I welcome her and we will have her address when she joins. May I have the CV of the chief guest, please? CV of Sulbha ma'am.
Yeah. Yes.
So it is a great honor to introduce our chief guest for the evening, Dr. Sulbha Joshi ma'am, who is a retired professor and HOD, Obstetrics and Gynae, NKP Salve Institute of Medical Sciences, Nagpur. She is the past president of IMS Nagpur, past secretary NARCHI Nagpur, past president NIPTB Nagpur. She is the secretary of Brain and Mind Museum Nagpur. She runs a Mano Marriage Bureau and Marriage Bureau for mentally or physically handicapped. So, ma'am, with your vast experience, we would like to have a few words from blessings from you.
Thank you, Dr. Suman. Good evening, everyone. My sincere thanks to Dr. MC Patel, Program Director, and Dr. Sneha, Convener for the invitation as Chief Guest, and my special thanks for bringing our Vidarbha societies, Nagpur Society, Chandrapur, and Mandara societies on one platform. I am very happy to see both the Lakshmis, Dr. Raja Lakshmi and Shrikhande Lakshmi, sharing the same dais with me. Friends, topics chosen for today are very appropriate in today's scenario. And with the galaxy of the speakers present today, I am very sure it will be a very, very enriching CME. My best wishes to all the panelists, all the speakers and the chairpersons. My best wishes to Sneha for her candidature for Vice President, and also to Dr. Kalpana, Jyoti Banglowala, Dr. Suman, Dr. Bharti. Wish you all the best.
Thank you. Thank you, Sulbha madam, for sparing time to bless us. Of course, you are always with us in any of our academic activity. And I also endorse your wish to all the contestants as far as Foxy's incoming election is concerned. You rightly said Dr. Sneha Buyar is contesting for post of Vice President Foxy from West Zone. Dr. Jyoti Banglowala is contesting for Chairperson Ethics and Medical Legal Committee Foxy. Dr. Suman is contesting for Vaginal Surgery Committee, and Dr. B. Kalpana is contesting for Infertility Committee, and all are with me in this my series since long. They all are hardworking persons and very deserving candidate. So I also endorse your wish, Madam Sulbha madam, to bless them, to support them for their future endeavor as far as Foxy election is concerned. Thank you, madam. Thank you for sparing time.
Thank you, Sulbha. Thank you very much.
I now again invite Dr. Asha Jain to invite Dr. Raj Lakshmi Sardas for her address.
Thank you, Dr. Suman. May I have the CV, please?
Yes.
So,
yeah.
It's a great pleasure to welcome Dr. Raj Lakshmi ma'am, who was born in 1945 in a family of doctors. Her father was an eminent eye surgeon, Dr. Madan Gopal, and mother was a very soft-spoken lady. She has been awarded. She practices in Rajamundry, Andhra Pradesh for 5 years, then in England for a year, finally Coal City of Chandrapur since 1977, back to India to serve her own countrymen. So she has the Land's Best Secretary Award in Andhra Pradesh in 1975, President Chandrapur Obstetric Gynec Society from 2001 to 2003, has been awarded B.K. Taft Trophy, and she's very, very active right now. She is near Coimbatore in Tirunelveli. Ma'am, she has also done her Sangeet Visharad in Hindustani classical music. So ma'am, we welcome you for your words of blessings for this webinar.
Am I heard?
Yes.
Yes, ma'am.
Yes, ma'am.
All of you, including, first of all, I must thank Sir Dr. MC Patel for involving me in such a academically, to make up, be again involved in academics. Because now, people, I wonder if they would call me to such functions. But it is great, and it's so amazing that we can meet so many people on such a small screen in such a short while and discuss such great topics. So this is very great honor for me, and I must thank you, the convener, the all the faculty and everybody for inviting me, and I give you all my best wishes and blessings, since at my age I can bless you all and ask for God's blessing to make this a great success. Thank you again.
Thank you so much, Rajlakshmi
Yes,
ma'am. You're an inspiration.
Thank you, madam. Thank you for sparing time to bless the webinar. Thank you, madam.
Thank you, Rajlakshmi Madam and Patel sir. Now I take the delightful opportunity to invite a great scholar and stalwart, Chairperson ICOG, Dr. Lakshmi Shrikhande Madam. Here we, Lakshmi Madam CV we want. Next. Iske baad wala, yeah. We can see here, she has a very illustrative CV. She is the national, as we all know, Chairperson ICOG, National Corresponding Editor, Journal of OB-GYN of India, Jogi. She is also National Corresponding Secretary, Association of Medical Women India. She is the founder, patron, and president of ISOPAR Vidarbha chapter from 2019 to 2021. And presently, she is chairperson, IMS Education Committee. She is also the president of Association of Medical Women Wing, Nagpur Society. And she is recipient of Nagpur Ratan Award by the hands of Union Minister Shri Nitinji Gadkari, and has received Bharat Excellence Award for Women's Health. She has also received Nehru Dara Hansotia Best Committee Award for her work as chairperson HIV/AIDS Committee during 2007 to 2009, and has received new appreciation letter from Maharashtra government for her work in the field of Save the Girl Child. She has served as Senior Vice President FOXI in 2012 and also as President Menopause Society in 2016 to 2018. She has also been the President of Nagpur OB-GYN Society in 2005 to 2006 and has delivered around 11 orations and more than 450 guest lectures. And she has more than 30 national and 11 international publications to her credit, and has sensitized 2 lakh boys and girls on adolescent health issues. Welcome, madam. We are eager to hear from you, your blessed words.
Thank you. Thank you so much, Dr. Suman, for your kind introduction. Friends, very good evening to one and all. And MC Patel, sir, I am very happy to be part of this 152nd edition of your Happy Learning Masterclass webinar series. And I am more happy because I am amongst the stalwarts of my own region, Nagpur, Chandrapur, and Bhandara. I won't take names because each and everyone present here, I know them personally. They all are my personal good friends, and wish you all the very best, MC Patel, sir, for your elections next year. People should not get confused. Your election is next year. And I know this webinar web series so is going great guns, and the topics you have chosen today are really worth appreciating. The IUI, the hormones, the ART Act, and first trimester anomaly scan, along with your choice of speakers, is simply fantabulous. I am here to learn from all my stalwarts who are speaking. They are giving their expert comments or they are participating as expert panelists. So friends, thanks once again, MC Patel, sir, and happy learning to one and all. Thank you for having me once again here. Thank you.
Thank you. Thank you, Dr. Lakshmi, madam, for sparing time. Of course, you are always with me in any of my academic or any other activity related to FOXY. So thank you. Thank you very much.
Thank you, Lakshmi Madam and Patel sir. And with this, we come to the end of the inaugural function. And I thank our chief guest, Dr. Sulpha Joshi Madam, our guest of honor, Dr. Rajalakshmi Madam, and Dr. Lakshmi Srikhande Madam, all the dignitaries, delegates for gracing the occasion. And now we move on to the academic sessions. And I hand over to Dr. Kalpana and Dr. Jyoti Banglawala for the further proceedings.
Good evening, everyone. Thank you, Suman. Actually, it is my proud privilege to be a part of this wonderful series, that to 152nd edition, organized by our program director, MC Patel sir, who is a medical legal expert, ready to help each and every gynecologist, and the convener being Sneha Bhuya ma'am, with wonderful societies, Bandara, Chandrapur and Nagpur. And we got blessings from senior most persons like Sulabha ma'am, Rajalakshmi ma'am and Lakshmi Srikhande ma'am, who is the ICOG chair and doing dynamic activities. We have been enjoying all the activities of ICOG every week. Thank you so much for your blessings. With the blessings, we are moving on to the panel discussion, which is a very interesting topic. And we have wonderful moderator, Manisha ma'am and Sushma ma'am. The topic being stimulation protocol in IUI. It is a great task to stimulate for IUI because ultimately we need monofollicular development. At the same time, we need to avoid hyperstimulation and multiple pregnancy. Our task is to maintain the success rate also. So I welcome moderators Manisha Gate ma'am, who is the president of Chandrapur Uji Society, West Zone Coordinator, Food Drug Medical Surgical Equipment Committee, FOGSI, Secretary ISOPAR Vidarbha Chapter, Chairperson Women's Doctor Wing, IMA Chandrapur 21 to 22. Madam was the Secretary 16 to 18, Vice President IMA Chandrapur, Director of Chandrapur Test Tube Baby Center, recipient of various awards, Director of Sahakari Bank Chandrapur, and she has the credit of bringing first colposcopy in Chandrapur, and probably she's an expert in oncology and infertility also. She has been invited faculty in various conferences, prestigious conferences. Madam's interest is laparoscopy, infertility, colposcopy. Welcome, ma'am. Our next moderator is Sushma Deshmukh ma'am, who is the director, Central India Test Tube Baby Center, HOD, Well Multispeciality Hospital and Research Center. She is the secretary Vidarbha IFS 21 to 24, president of NOGS 23 to 24. Organized various national, international conferences and workshops. She has been a regular faculty for Global Hysteroscopy Congress in Barcelona, almost for the past 6 years. That is a very great achievement. Written more than 25 chapters in books, and also published books in various prestigious publishers with JP and CBS Paras, conducting public awareness programs for adolescent, reproductive and menopausal age group also. Welcome, ma'am. We have experts for the moderator, Sneha Bhuya ma'am, who doesn't need any introduction, who is the convener of this program and also past breast committee, please, past breast committee chairperson, and madam is was the governing council member ICOG 21 to 22, Suffolk working committee member of breastfeeding, and she is the dynamic amongst chairperson of medical disorder committee 22 to 24. founder president of Vidarbha Isoparb. She has received various awards, MS Signature Award, GCC Award, SN Malhotra Award, Gurusha Community Award, Andibai Joshi Award, and she has got rich experience of almost 20 years in OBSGYN. Welcome, ma'am. Our next expert is Dr. Rekha Rajendra Kumar, who is a medical director of Miracle IVF Center, Chandana Hospital, Bangalore. And she has got almost 31 years of experience, President-elect Bangalore Ruji Society. She is the South Zone Coordinator of FOGSI Infertility Committee, Chairperson ART Committee, Kasoga 2022, received 15 prestigious awards, and she has been a very good teacher with 15 articles and many paper presentation even in ASHRAE. Welcome, Dr. Rekha. Our panelists are Dr. Bharti Rajshekhar, who is the President, Medical Director Vatsalya Hospital, Hassan, Honorary Secretary General, Kasoga 2022. She is into Red Cross also, IMA Karnataka State, past Vice President, past President of Hassan OG Society, and also PCPND committee member. She was a member of FOGSI, Food and Drug Committee, recipient of various prestigious awards, faculty in various conferences, conducted various workshops. Welcome, Dr. Bharti. And our panelists are Dr. Prajakta Aswar ma'am, who is a private practitioner in Chandrapur, Vice President of Chandrapur OG Society, past Vice President IMA Chandrapur too, and into IMA activities. Welcome, ma'am. Our next chairperson is Dr. Manisha Vazaid ma'am, who is the Secretary of Chandrapur OG Society. Welcome, ma'am. I also welcome Dr. Manoj Agalla, who is the consultant laparoscopic surgeon, infertility specialist, Bandara, Secretary of Bandara OG Society, past assistant professor in Nagpur. Welcome, sir. And also Meenal Bhu, practicing in Tamsar for the past 20 years, running 30-bedded hospital successfully. Madam's interest is high-risk pregnancy, infertility, gynec, lap surgery, currently treasurer of Bandara OG Society, interested in various social activities too. Welcome, ma'am. Our next panelist is Dr. Anjali Dangidote, who has completed fellowship in reproductive medicine and consultant in Nagpur, Icon Hospital, Bharat Nagar, Nagpur, and also various other hospitals. She is the EC member of NOGS, a life member of NOGS, IMA, and NASCHI. Welcome, ma'am. Our next panelist is Dr. Meenal Kalambe, who is the Assistant Professor, Department of OG, Nagpur, EC member of Nagpur. She has won various prizes in various conferences, panelist in various conferences, life member of various organizations. Madam's interest is high-risk pregnancy. Welcome, ma'am. Our next panelist is Dr. Chaitanya Shimbaka, who was the past president of Nagpur OG Society, chairman Infertility Committee amongst the Emergency Obstetrics Committee amongst, librarian of Maharashtra ISA chapter, member Infertility Committee, Clinical Research Committee, Endocrinology Committee, FOGSI, recipient of Karnira Yuva FOGSI Uration Award, Mema Signature Award, amongst V for Street Award from Maharashtra Governor, gold medal during his undergraduation, and also given oration, keynote address in various FOGSI societies, various conferences, published 20 articles, editor of Change Amongst book on infertility practices, editor of Amongst Handbook on Infertility, contributed almost chapters in 6 books, member of PCP and DT committee also. Welcome, sir. Our next panelist is Dr. Sharmili Padar, madam, who is a consultant gynecologist for the past 28 years, Director, Coal City Multi-Speciality Hospital, Chandrapur, past Director, CTBC, IVF Center, Chandrapur, past President of Chandrapur Uji Society. Field of interest is in emergency infertility. Welcome, ma'am. Over to you, moderator, waiting for a interesting panel discussion and cases.
Thank you, Dr. Kalpana, for elaborate CVs of all. Just I will share my a very good evening to all. At the outset, really we are all thankful to Dr. MC Patel sir and board of all happy learning masterclass series and all these members involved in it. And I'm extending gratitude on behalf of entire Vidarbha region. And I really appreciate their persistence and follow-up and affectionate invitation. Everybody was inviting us. All faculties must have experienced. And really since last 15 days, they are talking to us and really we are honored. So the topic today given to us is the panel stimulation protocols in IUI. And everybody here will agree that stimulation protocol is the heart of every IUI cycle. And we all love it from the bottom of heart. Every time again and listen, but again we join to listen these stimulation protocols. For our patients, it is heartfelt experience after the conception with whole heartful and thankfulness for us and connecting to hearts with the hearty feeling. So myself, Dr. Sushma Deshmukh, and with me, Dr. Manisha Ghate from Chandrapur, we are moderating this session, stimulation protocols in IUI. So now the season is really rainy season, monsoon is there, and we are discussing our academics. So I think friends will have some stories, different stories, because our OPD is like a different dramatic situation. Dr. Rajlakshmi Madam will understand because she has written many dramas. Every time new story is there. So in the same way, the ovaries, different type of also ovaries create different stories with us. So I'm going to put all the stories in front of you. So along with me, again, we are the directors, composers are Dr. Bharti Rajshekar, Dr. Prajakta Aswar, Dr. Manisha Vasade, Dr. Manoj Aglave, Dr. Meenal Bhure, Dr. Anjali Dangedhote, Dr. Milal Karambe, Dr. Chaitanya Shembekar, Dr. Sharmila Poddar. And dialogues are Dr. Sneha Bhuar and Dr. Rekha Rajendra Kumar. So just enjoy these different discussions. So now background of this story. We know that the ovary plays an important role in creation. And why do at all we want ovarian stimulation? Because everybody know that the active ovarian stimulation is a rational thing and it should be choice for any IUI and IVF because it increases number of oocyte, increases size of the ovary, so it comes nearer to the tube, and increase in oocytes causes increase in hormones, increase in hyperemia, improving fertility. So both ovulatory and ovulatory patients yield high pregnancy rates. So that's why superovulation is mandatory for all ovulatory and unovulatory cycles. But story is not so simple. It's easy to stimulate. We see that it's very easy to stimulate. There are many twists in this story. And because sometimes we become uneasy due to the odd behavior of ovary. Because when she's on and on, she is fired upon, going madly on hyperstimulation, sometimes becomes non-responding. If responding, becomes non-ovulating. If ovulating, not giving pregnancy. And nowadays, she has started aging prematurely. So we go on thinking and thinking, and we keep on changing and changing the drugs protocol this way and that way. But she keeps on escaping. So how to tackle her and how to take her? So how to stimulate in IUI? So my question to my dear panelists, anyone can take the questions. What are the type of patients and on which criteria we decide our stimulation? So anyone can take? Meenal?
Hello.
Or anyone? Yeah.
Hello. There are 4 categories of the patient as per FIGO guidelines.
Yes.
Hypothalamic disorder in which there is a hypogonadotropic hypogonadism.
Okay.
Then second is the pituitary with the PCO with normogonadotropic normogonadism.
Yes.
Third is with the ovarian pathology. This
Yes.
may be eugonadotropic patients, and 4th with the PCOS patients. So,
That is a WHO classification you're talking regarding anovulation and oligovulation. But in a simple way, we are having different types of category of patients. Anyone can take the question? Dr. Bharti, Dr. Prajakta.
Ovulatory and ovulatory symptoms. One is like a simple patient and one is PCOS patient, which we are tackling most in our routine activities. Then there is
So also they are
responsive, more responsive, and one, yeah, and they are less responsive. You can categorize the
so different types of patient, ovulatory, anovulatory. Again, according to the response, hyper responder, normal responder, poor responder, Dr. Manoj already explained it. So again, according to age and AMH and AFC, we decide, and there are various again problems, and we also consider the previous stimulation. So now we have patients in permutation combination for each of these things. See, normal response, poor response, hyper response, normal reserve, low reserve, and high reserve. So these are two different entities. Reserve relates to AFC or ultimate yield of follicles at the end of stimulation, and response relates to the sensitivity of the ovary to ovulation stimulating agent to produce these follicles. So it is very important to have a baseline scan also. Dr. Manoj already said that this type of the patient, there's a group 1, group 2, and group 3. Commonly, we are getting group 2 type of patients in already the PCOS patients. So now we are coming to our main discussion, intrauterine insemination. It's an ideal treatment of infertility, should be simple, safe, less invasive, cost effective, and also with good pregnancy rate. Intrauterine insertion fulfills all these criteria. And overall success, we know that is 10 to 15%. If you are adding gonadotropins, it will go to around 20-22%. But there are various options are studied to improve the IUI results. So how to improve pregnancy results in IUI? So there are many things, proper selection of patient, then the investigation, evaluation of male. But now we are restricting on the well-designed stimulated protocols according to the patient's follicular status and the attentional behavior of the follicle. So I think, Manisha, but we are constantly discussing about IUI. What do you think? Can we do IUI? Who can do IUI?
Yes,
What is
ma'am.
your opinion, Manisha?
Yes, ma'am.
Explain
Can I
please?
have the second, next slide, please? Yes. What about IUI? Who can do IUI? What are the criteria to establish IUI clinic? And anyone can speak on new ART bill. Can we have a discussion, a small discussion, then we will move on our first case. Yes, Dr. Manoj?
hello.
Yes.
Gynecologist having both a degree or diploma in obstetrics and gynecology can do IUI with having the setup with the workstation for the IUI,
Okay.
centrifuge machine, refrigerator.
Yes.
These are the basic requirements for the IUI lab.
Okay, okay. So let us go through the ART Regulation Act, which was formed actually to lay down the code of conduct to be observed by the person working at the clinics and the bank, and to set the minimum standard of physical infrastructures, the laboratories, the diagnostic equipments, and the expert manpower which should be employed by these clinics and the banks. So every clinic or a bank which is conducting ART partly or exclusively have to get registered and apply for the registration. And according to this ART clinics and the banks, they are classified at 2 levels. The level 1 ART clinic, it is only that who handles only do the IUI procedures only as the part of their treatment. And the second level is the ART clinic, which along with IUI, go for the other procedures and techniques also that attempts to obtain the pregnancy. So, according to this slide, the staff requirement, yes, you have stated about the qualification and the minimum equipment. So, the form and the manner of an application for registration and fee is payable therefore under the subsection which is already stated in our on the website of the ART registry, that is rupees 50,000 for the level 1 ART clinic, which when if you are doing only IUI in your hospitals, then consent for the intrauterine insemination with husband's semen or sperm as is specified in the Form 7 should always be taken, and consent for intrauterine insemination with donor semen as specified also should be taken according to the specified form mentioned in the ART registry. These are the minimal requirement to set up an IUI clinic. Yes,
So
madam.
we are already having a discussion with Dr. MC Patel, sir. So
Yes.
these are only the glimpses just we wanted to discuss before we start our discussion.
Yes. Can we have our next? Yes.
Now
Now,
start with the next story.
yeah. Now we are going to start with our story number 1. A 27 years old patient, married 3 years back. Her menstrual history and personal history are normal, having an average weight with normal BMI. All investigations normal, HSG normal, baseline scan was also normal, but her husband is Azus only. They are willing for, they have given their consent for the IUI with the donor sperm. What to do next? Yes, anyone? Dr. Manisha Basade?
Shall I?
Yes, sure. Anjali? Yes.
Yeah. Anyone?
So definitely this patient should go ahead with IUID after, as ma'am said, after proper consent and everything, and explaining the success rate and everything to the patient. We should definitely go ahead with stimulation of the ovary. Now, CC or LET is any of the two, depending upon the physician's choice. You can either go ahead with clomiphene citrate or letrozole. And to begin with, we can start with the baseline dose. If giving letrozole, we can start with 2.5 mg. Give it for first 5 days and monitor the follicular growth. And according to the maturation of the follicle, you give trigger and do the IUID.
What is your choice? Whether you are a clomiphene lover or letrozole lover?
Ma'am, my choice is letrozole. Yeah, I am preferring
letrozole would be our choice.
Who is clomiphene lover here?
Yes, ma'am. I will go for clomiphene first.
Yeah, good. Because yeah, it's had been tested since many years.
Yes.
Since 59.
Yeah.
Anyone
So
can.
first-
It's a discussion. it's a-
Madam, madam, please give your opinion here.
Yeah, please, everyone can talk.
I would
Yeah.
my choice is letrozole.
Okay, you are letrozole lover.
Okay.
Okay.
Shall I say something?
Yes,
Yes,
sure.
yes.
Huh.
Yes.
Dr. Chaitanya?
I think we all know that if you look at the guidelines of 2018, PCO guidelines for 2018, ESHRE guidelines clearly say that letrozole is the drug of choice for the ovulation induction in cases of PCO.
But this is
So
not
one
PCO patient.
category,
This is
no,
not a
that is what
PCO
I'm
patient.
saying. No, that is what I'm saying. One category is now gone. In PCO, there is no discussion. You have to give letrozole as a choice number 1. Now, as far as the other patients are concerned, like this patient which we are discussing, the choice of drug will depend on, of course, your comfort and your experience. At the same time, you have to look into the various advantages and disadvantages of all the drugs. Like clomiphene citrate is a drug which is good for stimulation, but it is not good for endometrium. So whenever you are giving clomiphene citrate, you should always have a look at the endometrium, and you may start estrogen on day 7 or day 8 whenever you call the patient, in case you find that endometrium is not good. Another thing is letrozole is good for monofollicular development. Clomiphene citrate gives good follicles, and therefore you may get very good results with clomiphene citrate. So clomiphene citrate is like old wine, and you must not forget that clomiphene citrate has still a role to play as far as the ovulation induction is concerned. So there are two factors. One is the individual choice, and second is have a look at the endometrium.
Only the what directly. This is very nicely expressed by Dr. Chaitanya Shembekar. Actually,
And
it
Dr.
is- it depends
because
upon the choice.
many times only, can I?
Yes, please.
Many times with the letrozole, we get only monofollicular, single follicle. And for getting the success, we need at least two follicles. So
Very well said, Meenal. That is very true.
But what
Yeah, you
happens
get good
whenever
results
you
with
are
clomiphene
using
citrate.
clomiphene, always look at the endometrium. And always
Yes.
that you cannot add estrogen also because it blocks the receptors. What is see the action of clomiphene? So it is always better that if you are observing that the endometrium is not good, you can directly switch over to letrozole.
If
But
the first
depending
cycle
upon
is
the
like that,
choice-
then the second cycle with the letters.
Yes,
Mhm.
please,
Yeah.
please.
Yeah, Dr. Sushma, I would like to add to one point other than what Dr. Chaitanya said. I agree with what he said. Other thing what I would like to add is it depends upon our or the other doctor's experience what the patient brings.
Yes.
Like sometimes letrozole, clomiphene, nothing may help her. We may have to go for a gonadotropin right from day 2 in certain cases, which we have done. Many of us have done directly from day 2. Also, we have started with the say 75 of gonadotropin, HMG, and this kind of thing. So that is also another factor that one has to consider.
Yeah,
Thank you.
but this patient is purely came not stimulated at all previously. Directly, she came from the IUID. So
Okay.
that's why you can start any stimulation according to your choice. That's why I asked this question.
Again, another thing is these kind of patients have a better success because it is most of the times it is purely male problem. Like she's never exposed to pregnancy anytime. So chances of D with a good, because we get a good sample, is better in these kind of patients.
So dose, how many cycles? Just anyone can just, we all know, but still we can elaborate because everybody will understand. Dr. Manisha.
Ma'am, we can, yeah. We can start. We can continue for at least 5 to 6 cycles of letrozole or CC, whatever the choice of the clinician. And if it doesn't work, I mean, if she doesn't conceive in 5 to 6 cycles, then we can switch to gonadotropins. Like we can start with low dose step protocol, and then accordingly we can, after the follicle matures, we can do the IUI, donor IUI.
Okay.
Maybe we will not wait till 6 cycles for add gonadotropin.
Yes, you can try with the 2 cycles.
Yes.
2 or 3 cycles, then you can add gonadotropins.
Add gonadotropins.
You can add in a sequential manner also, depending upon as patient is young. You can start gonadotropins from day 5, 6 like that daily for 3-4 doses, and you can see how the follicles are growing, and you can do IUI accordingly.
Yeah, Sushma madam, there is a formula
Yes.
for the success rate of IUI with the ovulation induction agents, and this formula says that if you try ovulation induction with clomiphene citrate or letrozole alone, it will give you around 10% of success rate. If you combine letrozole and or clomiphene citrate with gonadotropins, it will give you around 15% success rate. And similarly, if you give only gonadotropins, then also you get around 15 to 20% success rate. So the success rate of only gonadotropins and gonadotropin combined with oral ovulations is almost same, but the success rate of only oral ovulations in case of IUI is low. Therefore, I think we should start with gonadotropins and oral ovulation combination, because this is the combination which works better, gives you better results, and at the same time the cost is cut down because you are combining oral with the injections. Therefore, as you rightly said, we are giving only 3 injections, 5th, 6th and 7th, 6th or 7th and 8th day. Therefore, there is a cost cutting as well. So you get, it's a win-win situation. So combination works very well, and that is how you should start.
Really
Don't start with oral ovulations, but start with gonadotropins with oral ovulations. Combination.
We can have 1 cycle with oral ovulations. Then on 2nd or 3rd cycle, we'll definitely add gonadotropin.
Chaitanya.
What I feel is, yes, please.
Chaitanya, what I want to say, you said add the gonadotropins, but in which manner you want to add? Because you want to add it from the initial with the clomiphene or with the letrozole, or you will go after the completion of the 5 days of the letrozole or
you can
clomiphene.
What is your better preference? To start the preferred protocol is to start with day 2 letrozole or CC, give 5 days of letrozole or CC, followed by 6, 7 and 8 days of gonadotropins. This is a preferred protocol, because we actually do not let the gonadotropin window close, because on the 6th day there is a possibility that this window may close, and so before it gets closed, you start with the injectables and you do not let the gonadotropin window close. And second thing, as you have said that we can try 1 cycle of IUF and then go for gonadotropins. I personally feel that the number of IUI cycles, we are doing IUI since last 25 years. But initially we were taught that we should do 6 to 8 cycles of IUI. then the number came down to 4 to 6 cycles of
Yes,
IUI.
nowadays
Now
the
the
number is
number has gone down to 3.
Three
Only 3
only,
IUI.
yes.
So
Yes.
nobody is doing, because it's a cumulative success rate, which is important. And it is said that do not do the same thing again and again. So if you are not getting the success rate with 3 cycles of IUI, stop doing IUI. So you are left with only 3 cycles. Then you don't have much time. So you don't have time to experiment. So in that situation, it is better you start with the combination of gonadotropin with oral ovulogenics instead of trying and wasting 1 cycle of oral ovulogenics. So what is said is you don't have many cycles. So do the best. Give them the best so that the chances are more.
And
That is
actually,
what is
you
the
can
formula.
start the 75 dose. So you can just have better, because many times may not having the IVF centers, you can start with the simplified small dose like a 75 and just
Conventional
stick to the 75 dose and on again, but you have to monitor it with carefully. That is very important.
But ma'am,
Hello.
if we add it on the 6th, 7th, and 8th day, I don't think that will create much more problem, because already.
Yes.
Yeah.
Because already we are giving after the follicle has selected. So
Yes,
that's why
yes,
that
yes.
there won't be too much follicles.
Yes.
Hello, I am Dr. Lanjewar.
Yes,
Sorry
yes,
to
sir,
interrupt you.
please.
Actually, we are talking about the IUID. Then why to give the taxation of gonadotropin to the patient? Because we have not tried before this all ovulations or gonadotropin. Then why to not to go with the simple things like clomipene or letrozole?
Yes, yes. We are giving first cycle. Already that we are discussed, we are giving the cycle, and then we can switching over to the sequential regime.
Yes, yes.
But so we can start with the oral ovulations only,
Yes, yes,
and
for
then we
one or
can
two
add the gonadotropins.
Yeah, and then we
That
can
rightly
add-
said.
But it is always better to start with clomiphene or letrozole. Definitely letrozole preferred, immediately added by gonadotropins in the same cycle, the very first cycle, than experimenting as oral ovulagens in the first cycle and then add gonadotropin in the second cycle and so on. Because even if you don't want to experiment, patient will not stay with you for a longer time. They'll definitely go to some other doctor and give the best
Yes,
within
Rekha.
short
Yes,
span.
yes, exactly. Yes.
Yes,
And,
At the time, patient budget is also very important.
Yeah. And what about the trigger? Anyone can, those who have not spoke at all. Meenal, are you there? Sharmila? Trigger?
Sharmila madam?
Bharti madam, Bharti, Dr. Bharti, anyone?
Bharti madam.
Preferably, when we have serial ultrasound done, 18 millimeters follicle, I would go with single
Can
dose
you
of HCG,
just
HCG 5,000 units, we
Yes.
used the preferred method of
Ma'am, it's not audible.
just can you
Madam,
Yeah, now am I audible?
madam, still low. You can increase the
Still
volume of
it's-
your laptop.
yeah.
Yeah, I have increased it.
Come near to your laptop.
Yeah, now am I clear?
Now, am I audible?
Much better.
Yeah. Madam, if
Yeah.
it's a donor semen, should it be done by double IO should be done, I prefer. Because it's a double, because it's a donor semen. So let it be done a double IUI. The first one is 36 hours, 24 hours after the induction stimulation, and 24 hours after that, double IUI.
Yeah, Manisha, please just go on.
Yes,
Just
yes. Can I have the next slide, please?
1 minute. Huh?
Yes, madam. Yeah.
Yeah.
Yeah. We were just having a very good discussion about clomiphene or letrozole. Some are CC lovers and some are letrozole lovers. So yes, like respected sir, Lanjewar sir has stated, this patient can go for 2 cycles of ovulation like CC and letrozole. And if we are not getting the response, we can add gonadotropin in our onwards from our 3rd cycle. And then go. Okay. Then because the studies which states that gonadotropin versus clomiphene citrate with or without IUI in women with normogonadotrophic anovulation and clomiphene failure, a cost effectiveness analysis was done, and they concluded that in women with this normogonadotrophic anovulation who have not conceived after 6 ovulatory CC cycles, gonadotrophins are more effective, but they generate higher cost as compared to CC. So yes, we can give this benefit to our patient when they come to us for 1 or 2 cycles, because CC or letrozole, they are low cost, and if we are going to add gonadotrophin, the cost will is going to rise. Next cycle, please. Next slide, please. Yes. Now, the next question is, how do we monitor this patient? Yes, we go for TVS, then role of color Doppler, hysterolaparoscopy, problems in stimulation. If we come across the presence of cyst on day 2, what will be our management? And if we don't have any response in your stimulation, what about LUF? And in which conditions do we get the abnormal cycles, one by one? How do we monitor the cycle one by one? Yes, Bharti madam, can you start?
Yes, am I audible?
Yes, yes, ma'am.
Yeah. So, well, to monitor, ideally, yes, transvaginal sonography has to be the rule of the thumb, I would say. And of course, we would start monitoring it because we have put them on letrozole or clomiphene along with the gonadotrophins. I will start doing the scanning around maybe the 9th day and see whether the dominant follicles are coming up. And then follow up on the 11th day and 12th, 13th, 14th day till I see the follicles. And I will do the color Doppler also to see the endometrial vascularity as well as the regular transvaginal scan to see the size of the follicles and follow up with the growth of the follicles.
Okay, ma'am.
And hysterolaparoscopy, I think with this lady who has got only a male factor, I would not do hysterolaparoscopy in the initial follow-up. We have done the HSG, her tubes are patent, and a good transvaginal sonography will give us a picture of the endometrium and the ovaries. So I think hysterolaparoscopy will not be an initial investigation in this woman.
Okay. Yes. Again, when do we do the first scan of this patient?
That I will do when I'm doing her follow-up on day 2.
Yes, yes.
On day 2, we will do a scan, yes. And because we're going to rule out other concomitant pathology, and if there are any cysts
and
in the ovary also.
Be silent on day 2 or 3. They should not have
on
any
day
cysts.
2.
That should be our first criteria when we are patient.
Before we start them.
Yeah. Next, anyone want to add? Minal, you want to add anything? Okay, Chaitanya sir.
Manisha, it said that it's only related with this TVS, but we don't need any investigations or basic profile on day 2.
Yes,
yeah, of course, the AMH and the AFC.
Yes,
AMH and AFC.
Because they were all normal.
Have to be done.
Already stated.
Yeah, that's all normal. Yeah, that's
but
all normal.
Apart from just only
apart from that.
Yeah. No. That's not the thing. But apart from that, we should add the basic things also, like the TSH and the prolactin. Why not we should go for these things also simultaneously?
No, those are all done. They have said that all that has been done and they are normal.
They are normal.
So we have
stated that. We have done all the basic investigation for fulfilling the criteria of IUI.
Yeah, this is only when we are starting the stimulation when we have decided that it is only male factor infertility.
Next slide, please.
If we are...
Can we have a next slide? Yeah. So always think over that we require a day 2, day 3 TVS scan to assess the ovary. In the normal ovary, we expect the size of ovary 2 to 3 centimeter with the volume of 3 and 6.6 cc, and AFC per ovary should be 5 to 12 and have a isoechoic stroma. And the dominant follicle which it is growing can become apparently as early as the 5th day of the TVS. We can see that follicle. It could be identified at a mean diameter of 10 mm. Then it grows at a rate of 1.5 to 2.3 millimeter initially, and then 2 to 3 millimeter per day. And the diameter of the leading follicle is correlated with E2 levels and the endometrial changes. Next slide, please. So we start off monitoring the folliculogenesis, ultrasound examination, hormonal evaluation, day 2 to 3, and abnormalities can be large number of antral follicles like we see in PCOS patient and low numbers also. And it is very important to have a baseline scan in all the patients which are going for IUI. Next slide, please. Then again, this follicular monitoring, it involves the assessment of ovarian follicles and response of the endometrium simultaneously to the growing follicles. So again, we have to decide the oral ovulation according to our baseline scan and gonadotrophin also. Because gonadotrophin again require very close monitoring when we look at this patient. Then when the follicle, it matures around 18 to 22 mm of size with the volume of 3 to 7 cc, then we are able to see if we are having a good sonography machine. We can appreciate the sonolucent halo seen 24 hours prior to the ovulation and presence of cumulus. That means that the mature ovum in the follicle is present. And then regarding the Doppler, yes, it can be done. Vascularity surrounding at least 3/4 of the follicle is a good quality ovum that we interpret. And then the mature endometrium, it should be around 7 to 12 mm, triple line, we all know. Then endometrial grading is also to be done along with morphology and the vascularity. And all this, after doing all this, we go for the trigger of this patient. Next slide. Now we have to stimulate this patient. No growth of the follicles in the first cycle with 50 mg of cc. Then the dose is increased to 100 with the trigger of HCG 5000. And this patient, this particular patient, she ovulated in second cycle, but she did not had any pregnancy. So now, do you want to continue with the same dose or change the protocol? And how many months should one try for CC? The answer has already been given. We will give 2 chances and then we will move on to gonadotrophin also. Then again, this patient, she reported on day 2, the size of follicle was around 9 to 10 mm. Now, what can be done in such patient?
We should skip this cycle, let it go and wait for the next cycle, because presence of cyst can definitely, we cannot start ovulation induction with the presence of follicles to begin with.
Yes, very good. Because our first criteria is that ovaries should be silent whenever we are going to stimulate the patient for IUI. And this patient, they may then land up with the further problem of OHSS. Okay. Now, she was given 50 milligram of CC, but patient didn't come for ovulation study in the cycle. She reported on next menses day 3 with right ovarian cyst of 3.2 to 3.8 centimeter. Now, how to manage? Again, well,
just go.
Ask, yes.
Just go for a 2 month of OC.
Yes. Very right.
That will take care.
Yeah. So the RCOG guidelines and ACOG, they recommend that CC should be used for maximum of 12 months in patient's lifetime and for a maximum of 6 months consequently. Yes, which was already stated by us. Next slide, please. So now we will go on talking about the abnormal cycles for a few words. So in endometriosis patient and controls, there occurs significant difference in the follicular growth rate and total growth period. In the study, it was seen that in unexplained infertility patient, it was observed that a number of abnormalities like cyst formation and poor follicular growth is usually present. And in patient with low AMH, abnormal, irregular, and large follicles are frequently seen on day 2 to 3 of the menses. And impaired follicular growth was seen in luteal phase defect. When follicular size was below 15 mm, pregnancy was not seen or we did not get any pregnancy. And anovulatory and ovulatory dysfunction can easily be diagnosed by TVS. And again, we should know that anovulation is a result of HPO axis disturbances like in PCOS, which is the most important and most common disorder of infertility nowadays we are coming across. Next slide, please. So again, the role of antioxidant. Can anyone take this? What is your study or in your clinical practice? What is the role of antioxidant? What do you think about adding the antioxidant?
Antioxidants have been proven to be beneficial, especially if the patient is like advanced age or having endometriosis or maybe PCO for that matter, because these are known to be free radical scavengers. So they definitely help in betterment of not only folliculogenesis but also the quality of the ovum.
Okay.
So everybody.
I think in this particular case,
So everybody agree? Everybody agree?
Yeah.
And
Yes, I agree with that.
last 2 hours of stimulation protocols.
Yeah.
Hello.
So Sushma madam, please.
So
summarize.
what is the start with the clomiphene or letrozole for 2 cycles which are feasible. Dr. Bharat Lanjewara increased from 1 to 2 cycles because everybody many times see no one is so much well versed with the gonadotropins, feel afraid to start gonadotropins. So we can have 2 cycles. Meticulous follicular monitoring should be there. Laparohysteroscopy after I think 2 or 3 cycles one must consider, because there can be some adhesions or like that you can suspect. Add gonadotropins with for 2 more cycles. It can be sequential or complete, as already we have been discussing all this time. Then meticulous monitoring with the transverse sonography is very important. And always watch on abnormal stimulation. So in this story, the patient conceived with the 3rd cycle with clomiphene and the HMG protocol, because this doctor was a clomiphene lover. So we'll move to the next story. This is story number 2. Patient B, age 30 years, married 4 years back, irregular cycles 5 to 6 for 45-60 days with acanthosis nigricans, mild hirsutism, BMI 31, HSG normal, husband evaluation normal, willing for IUI, as very much anxious to conceive. So, what types of PCOS patient do you get in your practice? How will you manage oral ovulations, adjuvants, role of metformin? So many things are there when the patient is of PCOS, if it is diagnosed. So I think Dr. Sharmila, can you take this question?
Yeah, in my practice, PCOS patient, they may be either, most of them, they're obese PCOS, I may come across, and some are thin PCOS, lean PCOS, and some are medium PCOS, like they're not obese, but they're normoestrogenic, normal androgenic, but still they have polycystic ovaries. But for most of them are hyperandrogenic and obese PCOS. So in this case, obese PCOS, in this case, the story you told is a case more related to hyperandrogenic obese PCOS patient for me.
So we know that then PCOS can come in any permutation and combination. You cannot, one size is not fitting to anyone.
Yeah, shall I add one thing on some point?
Yes, please.
Yeah. Yes, exactly. That is what I was talking about.
That's
there are phenotypes
she
of
started
PCO.
this. That's a clinically what that I put that slide.
Yeah, there are phenotypes of PCO, and there are Rotterdam criteria which we all are applying in our clinical practice. Rotterdam criteria has classically classified PCOS into with 2 out of 3 criteria, where there is anovulation, hyperandrogenism, and insulin resistance. But here there is a NIH classification where they have added 4 phenotypes to the Rotterdam criteria. And this is a classification which is important for us, because you may get any PCO phenotype and you may be surprised to get some phenotypes where on looking at the patient, there is no flash diagnosis. You don't at all feel that she is a case of PCO because she is classical lean and thin PCO. There are some phenotypes where the ovaries are also normal. There is one phenotype where the ovulation is also taking place. So you get 4 phenotypes of PCO, and a phenotype A and B are classical phenotypes, but then C and D are mild PCO. And these are the patients where you may actually miss the diagnosis, and they are having symptoms of PCO. Some of them they are ovulating also. Some of them they are thin PCO. Therefore, you should actually classify the patient as per the phenotypes. This is one thing. And second thing is there is ethnicity which is involved. Now with nowadays I know at least 4 of my doctor friends whose daughter-in-laws are from Europe or from Spain or from Australia. So you are getting patients from everywhere all around the world, and therefore you should not only know about the phenotypes but also you should know about the ethnicity and its impact on the PCO, because this in Asia we have a very classical feature of PCO with classical obesity with hyperandrogenism, and these are the patients who are more prone for diabetes, and their insulin resistance is also very high. So this is the phenotype which is common in India, but we should know the ethnicity and its impact on the PCO as well. So one is phenotype and second is ethnicity.
So that's why PCOS is coming in different forms. Already Dr. Sharmila and Dr. Chaitanya Shimmarkar mentioned that it can be non-obese, it can be obese, it can be hyperandrogenic, hyperinsulinic, with CC resistance, with high dose of gonadotropins. Though we are not using CC nowadays, but still we can classify the PCOS undergoing IUI, IVF, and XA. So in a practical way, we have to just organize this story in this way so that we can give better this thing for the patient. So what's the management protocols? Can anyone suggest the management, how you can manage? Dr. Anjali, Dr. Manoj, Dr. Manisha, Prajakta.
I would, shall I say?
Advice you will give.
First of all,
yes, please.
She's obese, so I think we all agree that she should be advised some form of regular exercise and asked to achieve some weight loss. That will definitely help correct her anovulation. Secondly, addition of insulin sensitizers is also equally important because these patients invariably have insulin resistance. So metformin will be of great help to this patient. Along with metformin, myoinositol with dichloroinositol combination is also going to help her a lot. So I think we should give her, like prior to induction, this patient should be put on these adjuvants so that when she is on induction, she ovulates optimally, and thereby we can achieve optimal pregnancy rate. So usually what I do is put the patient on adjuvant for like 2 months or maybe 3 months along with some weight loss. And after that, start her on ovulation induction. Of course, letrozole is the drug of choice for this. And then go ahead with the routine protocol of IUI.
Okay, Manisha, you wanted to say something? Okay, yeah. Sharmila, Manisha, anyone can.
I want to add one thing, madam. These patients, they are usually mentally very upset and they need a good counseling. That's very important. That otherwise they are socially, they are get depression from their society, from their relatives, friends about their fertility. So mental counseling is very important in these patients. And
they are not willing to reduce their weight also.
Weight management is equally important.
Very difficult to tell them.
Yes, Sharmila, you have rightly said. They in 2018 guidelines on PCOS, there is a separate chapter on the behavioral aspects of PCOS, and there are many disorders like disorder eating and eating disorders. And as you have rightly said, the obesity can be a cause of PCOS, and PCOS may lead to depression, and patient may eat more because obesity can be because of depression as well. So
that's very important factor.
You are muted. Dr. Chaitanya, you are muted. Please unmute.
Sorry. Yeah, sorry. I was talking about the psychological aspects of PCOS, and there is a separate chapter on the psychological aspects of PCOS in the ASHRAE guidelines, where they have discussed various things like eating disorders and disordered eating, and the problem with the image, the body shaming. These are the things which are extremely important. We never think about the psychological factors, but they are having so many problems, and this leads to further depression, and depression leads to disordered eating, and there is obesity. So this is a vicious circle. They are already obese, they are having hirsutism, they go into depression and they eat more, and then they ultimately land up in more trouble. So as you have rightly said, Dr. Sharmila, this is a very important aspect, and you must do the proper counseling from a counselor or a psychologist so that they come out of this depression and vicious circle and they start ovulating and shedding weight as well.
Yeah, very nicely mentioned. Dr. Manisha, you wanted to say something? Dr. Manisha?
Ma'am, actually,
Yes,
everything
please.
has been.
But you can just have your opinion.
Yeah, I would like to add something like I would like to investigate this patient regarding her thyroid profile also, and her HbA1c and her baseline scan also, because that will give us the result of IUI. It will tell us about the result of IUI and what protocol should be chosen for this kind of patient. And it has already been discussed about the what protocol.
So we will come to that thing.
And
yeah.
Again, regarding surgical also, we can do like LOD can be done in this patient, but that is not the first choice. That will be the last choice for this patient.
That we'll discuss about yes.
Ma'am, one more
History
thing.
of diabetes.
When we start with, oh sorry, ma'am.
Please.
Ma'am will first finish your.
Yes, first finish and then one by one we'll listen to everyone. Just Sharmili.
Yeah. Madam, history of diabetes in these patients is very important because many of them, they are not aware about this fact that some of their distant or the near relatives, they have diabetes. And we should, as you said, she is androgenic, her serum insulin and serum testosterone level can also be done because hirsutism you said, mentioned in one of the few cases. So serum insulin and serum testosterone may be helpful in this case. As
Dr.
to add to Manisha.
Said, yeah.
Yes.
Dr. Meena,
that's the thing, and also we should go for the FSH and LH ratio on day 2. So let's see, because some of these patients they have with a high LH, and this type of patient they first need at least 2 months of the OC pills to get FSH LH ratio somehow in the normal range, and later on we'll go for ovulation induction. Means the things important is the fasting serum insulin, fasting blood sugar, FSH, LH, TSH, prolactin. These are the basic things that should be done on the day 2 of the this type of PCO patient. And according to that, if the patient is having the high FSI, fasting serum insulin, if he has a high LH or high testosterone level, so this type of patient, they must be put on the metformin for the first 2 months, and later on we'll think about the ovulation induction. And along with that, the OC pills works well because without normalizing their hormonal status and just starting the ovulation induction, I don't think the things will work. So PCO patient, first we should counsel the patient that she should get the regular cycle, she should have the normal hormonal status, and then later on we'll go for ovulation induction. Because if the patient is insisting, then there is no point. And along with that, we can add this all the adjuvant like vitamin D, myoinositol, D-chiroinositol, and rest. There are so many other things like a coenzyme Q10 and all the things. So with these things, by adding all the things, by advising weight reduction, these adjuvants, metformin, OC pills, these things, this correct the whole problems that's going in her body, and then later on, after 2 months, we'll go for the ovulation induction. I think with this way, we'll get some benefit, we will get some success in PCO patient.
Yeah, you rightly said, but what's just a little bit some change. The current guidelines of PCOS, they mentioned you can do the free testosterone level.
Yeah.
And they have not given importance to LH-FSS ratio, but still we can do. And even fasting insulin also, they have, because of the assays, there are problems in assays. That's why they said that there is no need of doing fasting, but still we can do just to support our diagnosis. And accordingly, it should be a comprehensive approach like counseling, then weight reduction, medical management, surgical, LOD. Actually, it should be very high resistant. It should be, we'll discuss about it afterwards.
Yes.
So the induction revolves on these important three things: induction or stimulation, then the modulators like adjuvants, and to improve the ovarian resistance. So if we have to work accordingly, so if you think about this, you can very well easily control these PCOS problems. What, Manisha, what do you say?
Yes, madam. The induction and stimulation should be in such a way that it should be planned meticulously so that we get, because this patient, they are already anxious and they want instant results for their treatment. And that will also increase their level of means confidence in most of the cases. So we have to vigorously form their protocols and treat this patient. And the drugs which we commonly used are the aromatase inhibitors like letrozole, CC. Yes, sir, Chaitanya sir has very nicely told about us about the role of CC and letrozole in this PCOS patient. Then the role of gonadotrophin. Yes, gonadotrophin play an important role. Most important is this gonadotrophin. They help in the increasing the quality of the oocyte, which we are going to use during the IUI. And the role of insulin sensitizers. Yes, there is definitely a role of insulin sensitizer in this patient of PCOS because they are insulin resistant in most of the cases. Again, adjuvants are to be used to overcome the ovarian resistance, like madam has rightly pointed that MCI and DCI, they are to be used. And again, we have to take the care that patient should not land in OHSS, that is ovarian hyperstimulation. Next
Which is very important, rightly said. Anyone would like to add? Already we have discussed about letrozole is the drug of choice. We can add gonadotrophins, insulin sensitizer, everyone mentioned. Yes, you want to say anything?
Madam, please explain how to use gonadotropin in PCOS patient so as to avoid OHSS.
Yes. See,
Madam,
already
madam, your expert comment.
Yes.
Actually, PCOS again comes in various forms. Already we have been discussing. So see, you have to see how the patients, some patients are very sensitive, some patients are resistant.
Yes.
So we have to find it, which patient is in which category. Suppose some patients are very sensitive. One of my patient in last week, even with letrozole also, 3-4 follicles are developing. So in such patients, we have to be very careful in adding gonadotrophins. Sorry, very difficult. So other patients are resistant. So you can the same way, from 6th day after letrozole, you can start adding, you can add FSH also, or the HMG also, depend, because in PCOS, they say that you can add FSH 75 milligram, or you can start with the lowest dose and just increase the dose. And but you have to meticulously monitor the patient by the transvaginal sonography. And even the more follicles developing, you can add antagonist also, you can complete your IUI. Very good antagonist protocol is there with the PCOS patient. So the main.
Sorry to interrupt.
Yes,
we are exceeding the time, so can you take one?
Okay, just
almost
just
10 minutes you can take.
Yes, okay.
So we'll go ahead, Manisha.
Yes. So we will go submit fast. Yes.
So already we have discussed all common.
But we can move forward.
The studies are saying letrozole is the drug of choice. So again, we'll go ahead. We'll finish the cases. So already we have discussed these guidelines. We can use the international guidelines saying that we can use even the Myonistor also, because they are suggesting some data is suggesting the ovulatory benefits. We don't know, but we need more data to confirm it. So the take-home message again, ovulation induction with IUI is a frequent choice in the treatment of infertile PCOS. It was the first line of treatment. It's a very promising. Gonadotrophins can be used, but we can use the antagonist protocol, and insulin sensitizers play a pivotal role in managing PCOS. And lifestyle management is very, very important. It should be considered, and as everybody mentioned, psychological aspect to be considered in PCOS. So this is a lady, 35 years lady, having one male child. Commonly, we must be meeting all these stories, not use any contraceptive. And now her son is demanding that he wants he want a brother or sister like sibling. Aim is 0.9. Husband evaluation normal. The couple decided not to go beyond IUI. Okay. They say that if it happens with IUI is okay for us, but we don't want IVF even if the AMH is 0.9. So what are the best protocols? Role of any adjuvants, DHA or counseling? Please.
She comes
fast.
under the category of
one sentence.
poor responders. And,
Diminished ovarian.
How you can give the best results for her in IUI?
She's a case of diminished ovarian reserve. So we will go for the combination protocol.
Yes.
We'll go for the combination protocol.
Yeah.
Anyone? First one
Anyway,
sentence,
no.
because we are
Yeah,
having
of course.
only 10 minutes.
We have to discuss 2 more cases.
Yeah, only just one sentence from everyone,
Yeah.
on all panelists. Which
One is
protocol? She said combination. One more?
Yes,
Manisha?
combination with letrozole and gonadotropins can be tried.
Yes.
And there's
Madam,
DHEAS.
I would
Probably
like to
you
add.
could put her on.
Okay, yeah.
DHA should be added. DHA should be added.
ma'am.
I think in such patients directly we can add gonadotropins from day 2.
Okay.
Because already AMH is 0.9. So because we should
And
explain
in-
counseling the ovarian reserve, how it is going down. So we should be very fast. So the counseling about
And in
the response
gonadotropin,
cost.
Sushma madam,
Yes.
HMG should be preferred
HMG,
over
yes.
FSH.
Yes.
HMG
Because it
should be
contains
preferred.
LH component.
And we should start with the HMG only. That is that's why I wanted only one sentence. Second,
Ma'am, if we add the HMG, should we start it from if we want to start with the CC plus HMG, then should we start CC on the day 2 and HMG on the day 3?
yes,
It's like
day
that?
6. Day 6 only, but combination we just start like that. Otherwise, why CC? Na? You can directly start with the gonadotropins, HMG.
But if the
Ideal-
patient
Yes,
is not
day 2.
affording, what to do then? If the
Then
patient
you
is
can
not
add
affording,
combination protocols, counsel the patient. These are your chances. These are the
Ideal
chances.
would
Then,
be
yes,
ideal
ma'am.
would be start with HMG 75,
Yes,
then
yes.
any other drug, and within no time, once you assess the response, you can shift to HMG 150 also with the
Yes.
pre-treatment of DHEA
Yes.
and vitamin D.
Perfect. Okay. Just
Next story. Yes, story.
next
number
story.
4.
Yes. Manisha.
Yes. 29 years old patient, married 3 years back with secondary amenorrhea since last 1 year. Her menstrual history was previously normal. She's average weight with BMI 25. All hormone investigations are normal, but there is low LH and FSH. And husband evaluation is normal. How will you get through?
So what is the diagnosis first?
What is the diagnosis?
Hypo.
Yes.
Correct. Yes. And then the management?
It responds very well to HMG.
Yes.
HMG will work in this case.
Yes,
HMG will be working, and one important thing we should be aware of ovarian hyperstimulation syndrome. Such patients land in ovarian hyperstimulation syndrome. So you have to be very careful in managing this hypogonadotrophic hypogonadism. And really, these patients respond very nicely, give very nice response, and you can get pregnancies also. Okay. So we have to look for the thyroid and prolactin also. So evaluate properly. If any other major cause, then start with the HMG. This category will respond nicely. Watch for OHSS. Okay.
Okay.
Manisha.
Yes, 33-year-old lady, married 8 years back. She has received treatment at many places. Her AMH is 2.4. HSG was done 2 years back. She is not willing for IVF, but she has history of dysmenorrhea since 3 to 4 years. And husband's evaluation has come normal. So what will be your next step in such patient? What is the diagnosis, first of all?
Secondary dysmenorrhea, it is suggestive of endometriosis. So I think hysterolaparoscopy would be advisable for the
Polyp in these cases?
Now, why
Yes.
hysterolaparoscopy?
Why not polyp in these cases?
In mild cases?
Polyp, endometrial, polyp.
Pardon?
In
We are not
polyp,
able
I
to
don't
hear.
think she will have dysmenorrhea. If she's having endometrial polyp, she won't have dysmenorrhea. That
He's already
Actually,
married since 8
8 years back.
Yes.
She is married
Married
8 years
8
back.
years.
33 years
Dysmenorrhea, now
old,
this is a better
very
having
fast.
dysmenorrhea.
Even though AMH is 2.4, there can be lab variations. We cannot rely on one parameter.
Yes.
We have to go very
Yes.
fast.
Madam, you should also look for PID in this case because she had a lot of treatments taken at, so handling has been done, but whatever, so PID should be also looked for. Tuberculosis.
Okay. Anyone
And
would like
UAG
to add
findings
anything?
is not mentioned here in this case. UAG findings?
Yes.
There are no UAG findings?
UAG findings are normal.
UAG findings normal.
Normal is corresponding with the AMH 2.4.
Okay. There's no
I think
adenomyosis or
laparoscopy is
like that
not
also.
the treatment of choice.
Yes, please. Dr.
Laparoscopy is not a
Yes.
treatment of choice in
Yes.
this case. It is said that diagnostic laparoscopy has no role to play in endometriosis
Yes.
because the 3D ultrasound is giving excellent results and you can diagnose almost all the pathologies with the help of 3D ultrasound. Therefore, laparoscopy should be only reserved for the patients who are having severe dysmenorrhea and who need treatment for this dysmenorrhea. And diagnostic laparoscopy is not the treatment of choice, but it has to be an operative laparoscopy, and that too with the counseling of the patient, that this laparoscopy, if at all she is having, say, endometrioma or a chocolate cyst, then you have to counsel the patient that this laparoscopy may relieve your pain, but will drop down the AMH levels. So AMH levels will go down, and the counseling should be done about the possibility of decreasing AMH level because of the surgery. And therefore, surgery is not the treatment of choice in the patients of endometriosis these days. It has to be kept as a treatment for severe dysmenorrhea or severe pain.
No, but in this patient, it may be endometriosis, it may not be endometriosis. But with 8 years infertility,
Madam,
33 years
can
old,
be cervical stenosis?
so
Yes, madam.
I think we should go for laparoscopy, and even though there are guidelines are there are weak recommendations, but operative laparoscopy could be offered as a treatment option for endometriosis associated infertility in the revised American Society of Reproductive Medicine, stage 1, stage 2, as it improves the rate of ongoing pregnancy. So they have mentioned it, but these are weak recommendations, and the GD recommends the decision to perform surgery should be guided by the presence or absence of pain symptoms. Already Dr. Chaitanya Shembekar rightly said.
Yes.
I feel in this case, there is a role of diagnostic, at least histolaparoscopy, consent being taken for both, because one is you may diagnose early endometriosis as you have put stage 1 and 2, like salt and pepper appearance, etc. Also, you will look deep into the pouch, find out what is the problem exactly there in this kind of patients, because her ultrasound is normal and in early endometriosis, it will be normal.
Yeah, and already Dr. Sharmila mentioned there can be PID, there can be tubal adhesions. So we have to rule out everything because she's having 8 years.
Get the idea of the tubal status also.
Most of the time we do laparoscopy for improving the anatomical relationship of the tube and ovary, so that we get higher chances of fertility in this patient when we proceed for IUI or I.
And both are complementary. It should be always combined with the hysteroscopy.
Yes.
So many times you can see undiagnosed things.
Can see also.
So that is very important. Yeah. Do we have time, or shall we stop?
2 minutes. Yes. Last story. Our last story is pending.
Already exceeded time. Sorry. Can we stop it? Because that's
sure. Okay, we'll stop it.
Very nice panel.
No problem. So that
Nice to hear you
evaluate
again.
properly. Thank you, panelists. It was a wonderful discussion with you all. Evaluate properly. If no other major cause, then start with proper history. This category will respond nicely. Watch for OHSS, all these symptoms. But don't forget, we have to go a long way to go to keep your promises, lots of things to do, to charge and induce our brain, stimulate again and again. So thank you very much to give a wonderful gift to the patient.
Yes. Thank you so much to all the panelists
Thank you.
and the experts which we have today.
Really.
We got
Thank
a
you,
lot
experts
of
and all.
things to learn from you all.
Thank you. Excellent panel. Thank you so much to the organizers,
Thank you.
MC
Big round of
Patel,
applause
and
for two
excellent
learned
moderators and experts
Thank you, sir.
on the panel.
Thank you very much
you.
for giving me this opportunity. Thank you, sir.
Thank you.
Thank
you,
you,
giving us the opportunity. Yes.
Dr. Sushma Deshmukh Madam and Dr. Manisha both have nicely moderated the panel, and all the panelists who have participated made panel very interesting and live. So big round of applause for all the panelists, two learned moderators.
The panelists really were very brilliant.
Yes.
Wonderful moderation, Sushma and Manisha.
Interesting
And
story.
excellent inputs of the panelists. Sorry, I was.
Sneha, we were missing you. We were.
Yeah, I know. I was delivering a talk, so I could not join earlier. Thank you so much, all of you, for joining, and it was wonderful. I was listening to you all.
Yes, madam, and our best wishes to you.
Okay, all the best,
Thank you.
Sneha.
Yeah.
Thank you. Thank
Thank
you,
you, ma'am.
I
Thank
seek
you,
your
moderator.
best wishes and wholehearted support. Thank you.
Dr. Bharti has joined.
Yes.
Yes.
So
Sir, I am here.
Yes, she is
here.
contesting for post of
NCD committee.
Chair.
NCD committee, sir.
So
Please support me.
Non-communicable
Request.
disease committee, new committee in Foxy, and Bharti is very deserving candidate for the same committee. So
Thank you,
please,
sir. Thank you.
please, sir, for
All the best, Dr.
supporting.
Bharti.
for the same.
Thank you very much, madam.
All the best, madam.
All the best.
Thank you, Dr.
Aarti,
Manisha.
Dr.
I
Sneha,
request
Dr.
all of you to
Jyoti.
support you, sir. Thank you,
Namaskar,
Rajlakshmi
Rajlakshmi madam. Namaskar. Namaskar, namaskar.
Thank you, Dr. MC Patel, sir,
Yes.
for your blessings and support.
Yes. Oh, yes.
Our best wishes with everyone who are contesting for the election.
Yeah.
you, Manisha.
All the best for everyone, and you are going to win.
Yeah.
Thank you. Thank you.
Thank you.
Tell me,
Yes, we can switch over to another topic.
Jyoti.
yes, yes. Thank you. And really a nice panel by Dr. Sushma and Dr. Manisha, and every participant means the experts and our all panelists give a very take-home message. After every case, the take-home message was very crisp and very good. Thank you very much. Now we are moving to session 2. This is the session 2 is the
Any session 1?
yes, session 1. Piyush, session 1 means talk.
Talk, yes.
Yes. The session 1 is the Lochai Hormones in Infertility by Dr. Shivani Jagirdar Madam. For that, I am inviting as chairperson Dr. Pragati Khalatkar Madam from Nagpur. Dr. Pragati Khalatkar is the Honorary Secretary of Nagpur Afghani Society, and she is the faculty in the Pelvic Anatomy Revisited Workshop, International Faculty FIGO 4 years consecutively. She got the Wonder Foxian and Amogazin Award. And apart from them, she is the multi-talented girl, and everybody can vouch for her talent when she conducted all the ramp walks and everything. And she's a fun-loving girl with all the leadership quality. We welcome you, Pragati. Our second chairperson today is Dr. Priya Shinde Madam. She is consultant obstetrician and gynecologist at Shinde Multi-Specialty Hospital at Chandrapur. She is the ex-secretary of Chandrapur Afghani Society and co-chairperson in WDWIMA Chandrapur in 2023 to 24. She is ex-lecturer of Savangi Medical College, Barda. She is
Thank you for the introduction. We will move because we are shortage of time, I think.
Yes, yeah. Our third chairperson is Dr. Anuradha Ridorkar Madam. She is the senior consultant at Kingsway Hospital, Nagpur. She is the past president of Nagpur Afghani Society and past chairperson of Maharashtra State Women Doctor Wing. She is a winner of Maharashtra government's Dr. Anandibai Joshi Award for Mother and Child Care. She is the first from Vidarbha to deliver prestigious Yuva Foxy Oration and recipient of IMA Women of the Year and Bhaskar Women Award. Namaskar, Anuradha Madam. And she is a winner of several best papers and posters at local, state and national level and quiz master at various zones. Her hobbies are public speaking, reading, acting in drama, and played a lead role in famous Marathi play, Ti Fulrani. I request Pragati Madam to introduce our speaker. Please put the CV. Yes. Pragati, the mic is handed over to you. And I request our second chairperson, Priya Madam, to open the topic to say something about the topic. And I request Anuradha Ridorkar Madam to sum up the topic after the talk of Shivangi Madam.
Thank you so much. A very good evening to all. I'm so happy to be part of Happy Learning. And it's already crossed a century and targeted so many people with so much of happiness and learning. And today I have a great honor to be chairing a session of my beloved friend, Dr. Shivangi Jagirdar. She is a gem of Nagpur and she is practicing obstetrician and gynecologist, infertility specialist since last 15 years. And her field of interest are safe obstetrics, infertility, adolescent PCOS, cancer awareness. And apart from that, she is full of art. We can see her performing her artistic talents so many places and a very good organizer. Shivangi, please come for your Harmony Locha. And I know you're going to make people mesmerized by your talk.
I request Priya Madam to just give some input.
Good evening, everyone. At the outset, I want to thank you for giving us this opportunity. Our first talk is the Locha hormone. The panel discussion on very important topic of IUI and infertility endocrinology is the backbone of the subject. And Dr. Shivangi is here to give insight on the hormones. I welcome Dr. Shivangi.
Yes. Am I audible to all?
Yes, Shivangi.
Okay.
So at the outset, I'm really grateful to be amongst such stalwarts. I'm listening to the CVs of all and they have great CVs. I don't have one, but then I'm happy to add into my CV today by being in this session. Thank you so much, organizers, especially the Dr. MC Patel sir and Dr. Sushma Deshmukh ma'am for including me here. My topic, which I have selected today, is named Loci hormones in infertility. And as I have selected the word locha, which itself means complicated or complex, so I have put the presentation in a very, very simple way to unfold all these lochas which are going in our minds and in the patient body during our infertility investigations.
Shivangi, can you make
Yes.
slide share so we can see it completely? We
Yes,
can make
ma'am, it is on the slide share only.
But I don't know, I'm able to see your side grid also.
Yes.
Shivangi, make it full screen.
Full screen. Make it full screen.
Ma'am, from my side, it is on a full screen only. Okay, okay. I'll just check.
Or you can log out and log in again. Then also.
Yeah, just a second, just a second. Is it stopped now?
No, it's coming in part.
Shivangi, stop screen share and again reshare.
Slideshow, if you will do, so you will get full screen.
No. First, stop sharing now.
Okay, okay.
Shivangi,
okay.
stop sharing and reshare, and then you make full screen.
Is it there now?
And now it's done, Shivangi. You can move
Okay,
on.
okay. Yes, yes. Thank you for the feedback, ma'am.
Loci hormones beginning, isn't it?
Yes, yes. The locha has already begun, ma'am, with the screening of, the share screen and everything. Yes, yes. So what I want to say is because of all these lochas, I have kept it really simple and few tips to start with while dealing with all these hormones in an infertility patient that we have to keep it really, yes. So we have to keep it simple. We don't have to forget the physiology while dealing with all these hormones. Don't overread the reports. Never miss the drug interactions. And finally, never give up. So just to start with, we have to brush our knowledge. Hormones are the chemicals synthesized and produced by specialized glands to control and regulate the activity of certain cells and organs. And we all know that fertility is a fine balance of many hormones working here and there in the female body. To name them, anti-Mullerian hormone, follicle stimulating hormone, the LH, the TSH, the prolactin, the DHEAS, testosterone and insulin. We have just heard the IUI discussion and all these hormones were appearing here and there in all that discussion. So to start with, let us clap for this hormone, which is the dawn of investigation these days, AMH, the anti-Mullerian hormone. It is a glycopeptide produced by the preantral and the small antral follicles, and it is acting as a game changer in the treatment of infertility. So definitely it is taken more or less as the indicator of ovarian reserve. This is the basic chart which I have taken about AMH, which says that the normal values range from 1.5 to 4 nanogram per ml, whereas the low values are depicting as less than 1 ml, and the high values here are suggestive more than 4 nanogram per ml, which are the PCOS cases which we were discussing right now. And why is it considered the best test to predict ovarian reserve? We all know that there is a dictum that AMH remains constant throughout the cycle and it can be checked on any day of the cycle. So that is the simplicity of checking this hormone. And so it is considered as the best test. But there is something more to know about AMH with us now, that it differs with age. Every time we just cannot go with the report and label the patient as low AMH or high AMH or so. You can see the chart. This chart I found very interesting because for the normal age group 18 to 30 years, the high AMH cutoff is coming to around 13 to 14. You can see the range, whatever is depicted in the chart, and we say it is 4 and 6, and above that are the PCOS patients which are responding more and which have the risk of hyperstimulation. So while dealing with all these hormones, we have to keep in mind the physiology which may act here and there. And as the age advances, definitely the range reduces to 1.3 to 2.9, that is around 3. Another chart which came in front of me, because we deal the patients with the reports. The patients are the reports to us, whichever are coming. So here we can very well see that the normal low ranges are depicted as 0.7 to 0.9. Many a times a 0.9 patient is coming to us and we are right and left labeling her as a low AMH and tell her everything about IVF with the donor oocytes coming into picture. So there are much variations to it. We have to correlate the things very well. This chart is saying something other, the other chart is saying something other, and the reports are coming day in and day out. But there are certain cases which can be considered as the gone cases as far as AMH is considered. Very low AMH, below 0.08, we don't have to give much hopes to this patient apart from a word saying miracles do happen. So the thing is 0.08, less than 0.1, yes, these are the cases which are really the gone cases, and less than 1 also we have to counsel in a very guarded way as far as AMH is concerned. What about high AMH? As I said, the charts say 18 to 30 years, 13 is considered as the normal range itself. So you have to see the AFC as well while reading the AMH report, and then to correlate the things, just not that a patient is having. Recently, one of my patients who very first time appeared in my OPD, she was having an AMH of 3.5 only. But surprisingly, her LH level was more, 25 it was. And I down-regulated the patient in 2 cycles, stimulated in 1 cycle, she came out with 3 triplet pregnancies. And the AMH was 3.5 only. So the surprises are coming here and there, and you have to keep the alerts on. Because these patients, they are the severe non-responsive type of PCOS, and when they respond, they go into the risk of hyperstimulation. They are also they also need high force to stimulate in all these cases where the AMH is really very high, and the long-term complications like OHSS can come into picture. So not only AMH is the answer, but we have a good love triangle of AMH, age, and AFC together while dealing with the patient, and we have to keep the clinical acumen on every time. Do you want to repeat the AMH? Ideally, there are no gains of repeating AMH for the low AMH patients because there are no 100% proven drugs to improve AMH. But the trial drugs are running with the statistics gaining day in and day night. So DHEA, antioxidants, aspirin, arginine, we are giving all these things to improve the AMH of the patients. So quarterly repetitions are recommended for the low AMH patients. And definitely after ovarian drilling, we want to repeat the AMH as to see what is the gain of this drilling procedure. We have already studied much about AMH, but more studies are needed. So let us see something new. What till now I have said what everyone was knowing. So AMH and FSH levels both have to go hand in hand. As my talk is pertaining to non-IVF infertility, I personally believe that when a patient makes a mind of going to an IVF center, he sets his budget and go there and he's ready to do everything and anything, whatever is advised. But then when it comes to a non-IVF infertility practice, we have to be really judgmental as to what we are doing with the patient. And here, only AMH, I don't believe, because FSH levels are also to be added, day 3 FSH levels specifically, because together they give the quantity and quality of eggs, a ratio which we can keep in mind. And it has to be combined with day 3 FSH, and we have to decide as to what cutoff of FSH we should take, wherein the patient has to be sent directly to the IVF center rather than keeping her at our centers, because this discordance start occurring at some point, and we have to read it where both are reassuring, then one is concerning, other is reassuring, and when both are concerning. So we should not reach a stage where both are concerning and then send the patient to some other center where also she gets a failure and nothing else. So the dictum which I have heard all the times, that AMH levels don't vary throughout the cycle. Yes, I found something new, and so I added it here. For the aging ovary pattern, yes, definitely less than 1 nanogram per ml, there is a minimal variation throughout the menstrual cycle. But for a younger ovary pattern. I kept that slide as it is because it is very interesting that for the younger ovary pattern and with a high level of AMH, which I said 13 is taken the cutoff normal, there can be variations in the overall cycle. Few studies are coming up with this. We may be able to comment on this maybe a year or two later. Yes, the birth control pills, they do suppress AMH level as we do the down regulation of all these patients, and egg donors using birth control pills for contraception are being rejected just because of their low AMH levels because of that. And the most important thing I want to stress here is low AMH level is not predictive of decreased chance of pregnancy in young healthy women. If there are no other factors, we have to keep this in mind. Coming to the next hormone on the board, follicle stimulating hormone. It has the work of pushing all the follicles in the further direction. It is a glycoprotein dimer with alpha and beta subunits. The beta subunit is unique, but the alpha subunit is correlating with other hormones as well. And as the name suggests, it stimulates folliculogenesis and it increases the recruitment of follicles as well. This graph is very important in our clinical practice where we have to understand the concept of the FSH window. FSH, it starts rising as the cycle begins and push a few of the follicles into the system, the cohort of the follicles, out of which one or two dominant follicles are taken and they start secreting estrogen, which lead to the negative feedback on the FSH, and the FSH suddenly drops. And this comic picture will tell you all, once the FSH suddenly drops, there is only one or two follicles which are going ahead with the low FSH level, and they take that I am taking the charge of the ovulation mission now, and beautifully say to the other follicles bye-bye, that the other follicles are going into apoptosis, and then they say that, oh my friend, your sacrifice will not go in vain. So FSH, yes, it is definitely a very important hormone for the cycle, but do we really want to check this FSH? As I said, in many cases, we have to do it with the AMH to check whether at what point we should push the patient towards IVF. But as it is variable with the phase of the cycle, vary with the previous cycle intake of OC pills, and above all, the normal values doesn't ensure that your ovarian reserves are good. So what is the point in doing such a test which is not giving any foolproof answer to anything? The normal values on day 3 should be less than 10 nanogram per ml. Coming to LH, I think it is the trump card in your hand, which you should use very, very cautiously. LH levels also vary according to the cycle phases, but I personally prefer to check day 3 LH levels in natural cycles just to differentiate between the low LH and the high LH cases. And if the LH is very high, they also help us to differentiate between the more androgenic cases with less response, then more chances of miscarriages. And as I said recently, one of my patients with LH 25, she gave a surprising triplets in the very first cycle. The LH surge, which is very, very popular and very important in infertility practice, we have to understand this LH surge very well. As I said, the FSH levels drop with the negative feedback of estrogen secreted from the dominating follicle. The LH level has a positive feedback effect, and hence it goes into a surge, and this surge is very helpful in the very, very important process for what we call ovulation. Coming to other hormones on the board, DHEAS, it is a male sex hormone present both in men and women, can be converted into female hormone estrogen, produced mainly by the adrenal glands and by ovaries and testicles as well. It has a role in improving the pregnancy rate in young women with premature diminished ovarian reserves. And we all are using DHEA in all these patients with diminished ovarian reserves. Also, one interesting fact that it decreases the age-related aneuploidy and miscarriage rate in older women with age-related diminished ovarian reserve. So it is in all a helpful hormone, but even if we check this hormone by lab, we are going to start DHEA for a diminished ovarian reserve. So we are not doing anything extra. So there is no point in putting a burden on the patient for unnecessary lab tests, specifically in non-IVF infertility. These are the normal values. Yes, it is raised in congenital adrenal hyperplasia and the PCOS patients as well. Coming to testosterone, it's an androgen, a male sex hormone that plays a role in reproduction, growth, and maintenance of healthy body, mainly produced by testes in men. In women's body, produced by the ovaries, adrenal glands, fat cells, and skin cells. And Females make about 1/10 to 1/20th of the amount of testosterone as men's body, but the PCOS patient, they are ahead in everything. So they are doing it more, and definitely they are having the androgenic symptoms. As far as infertility is concerned, testosterone has a role in the sex drive, in the menstrual health, and in the vaginal health. The vaginal dryness is very much common in the patients who are having low testosterone. So normal levels 15 to 70 nanogram per deciliter, and less than 15 nanogram, they cause fertility problems, low sex drives, missed or irregular menstrual periods, and vaginal dryness, which can be a very much a cause of infertility in some of the cases. So we need to take a very particular history, leading questions to be asked, and then to check definitely if androgenic symptoms are seen in the patient, we have to go for these tests. If it is more than 70 nanogram, yes, we are seeing it in the form of acne, hair excessive hair growth on the face, lack of menstruation, and PCOS definitely. Coming to insulin, hyperinsulinemia or insulin resistance, which we all were discussing, mostly seen in obese patients, but many a times very well seen in the lean patients as well. Hyperinsulinemia, what I believe, is mainly a clinical feature as far as obese patients are concerned. But as we have discussed the various phenotypes of PCOS patients, we have to check something related to the glucose metabolism in all these patients. Let it be fasting serum insulin, let it be OGCT, or let it be HbA1c, which are helping us to decide whether we have to start with the sensitizers in all these cases. I always believe we should go with the evidence-based practice. So placebo drugs should not be given, specifically metformin. Yes, it is working very well in patients, but the GI side effects are very much. So we have to be evidence-based and check either or the other thing to rule out the glucose metabolism disturbances in all these patients. As I said, it is a clinical feature. We can make out which patient is having insulin resistance. Specifically, if acanthosis is there, we may not need to check for the insulin levels as well. If clinical acanthosis nigricans is present in a patient, she has to have an insulin resistance, and we have to go with the drugs which are helping. Coming to thyroid stimulating hormone, glycoprotein produced by the anterior pituitary. It has a role everywhere in the body, thyroid hormones. Hypothyroidism is mainly related to fertility in the form of disruption of menstrual cycles, infertility, interference with the ovulation. Then again, there are increased risk of miscarriages and premature birth as well. Yes, the tests are TSH, T4. All these patients who have a long-term infertility or maybe a secondary long-term infertility, we need to go for the anti-thyroid antibodies as well to rule out the other factors. Thyroid profile, we need to check the anti-thyroid antibody for long-term infertility patients. But many places I found in the literature, they say do the lab test for thyroid only if they are having thyroid symptoms. But I don't believe this. I've just included it as found. Coming to prolactin, hyperprolactinemia is the presence of abnormally high prolactin. We all know it is a hormone produced in the pituitary gland and mainly related to the breast milk production for a newborn baby. And so it causes anovulation definitely, because the time after delivery, it is a time of anovulation. We all know many things: infertility, irregular cycles, changes in the menstrual flow, then loss of libido. These loss of libido, vaginal dryness, these are the complaints we are neglecting, which have to be very much taken into consideration while dealing with the patient of infertility. And yes, prolactin levels, we don't check right and left, but then we have to be really aware of the reports while seeing for prolactin, because it is a very sensitive hormone and it may have many drug interactions such as antipsychotic agents, antidepressants, antihypertensives too. They are fluctuating the prolactin levels. So not only the report, but report plus the patient should be the dictum everywhere. So coming to the end of my talk, hormones at a glance. Yes, FSH to be checked day 3, day 5, if at all you want to check, and it should be maximum up to the 10, and the lower border is 3 milli-international unit per ml. For LH, again, it is 2 to 3 for a lower one, 10 for a higher one, provided it is checked on day 3 to day 5. Estradiol, I don't check estradiols. I check estradiol only in one case: if a persistent cyst is there every time, we are seeing the cycle on day 3, a cyst is there, a cyst is there. So we have to rule out whether it is a functional cyst or a non-functional cyst. Then only we have to go for the estradiol levels. Otherwise, there is no point in checking for a non-IVF infertility. Then coming to prolactin, as I said, 20 nanogram is the cutoff, but many times up to 29, 30, 35, patients are not having any galactorrhea, any symptoms, anything. So we may be watchful and we can repeat it after some time just to be really sure. Progesterone levels, yes, I have not included this slide, but this is very important to know that where to check progesterone in a normal infertility patient. Yes, if you are getting a patient of LUFS again and again, luteinizing unruptured follicle, and we are really not sure whether the ovulation is occurring or not in all such patients, yes, we can take a step ahead and check the progesterone levels. It is to be checked on day 21 of the cycle. And AMH, as I said, is the hero or the heroine of all the hormones. It is to be checked anytime, and the levels may vary, but then above 5 or 6, we are definitely considering as more, and we have to be vigilant in all those cases. So before going on to all the lab tests, we have to have a reminder for all of us that don't do unnecessary lab tests for a normal patient. Always consider the physiological variations in hormones. Always correlate clinically. Repeat twice to be sure. Never give up, as miracles do happen. Thank you so much for patient hearing.
Thank you, Shivangi. Thank you. And it's excellent, actually, slides and the deliberation and what the Thalaiva and the dawn, everything. So I request Anuradha Madam to just conclude this lecture. Anuradha Madam, are you there? Redorkar Madam? Priya, you and Pragati, please do.
Yes, Shivangi, it was excellent and a lucid presentation. Very well, you have elaborated each hormone, where to do and where not to do, and how to take clinical findings into consideration while ordering the hormones was very nice. And as Dr. Jyoti has said, that your Lochai style was very good of putting the slides.
I hope I've simplified the things and I've justified my topic.
Actually, this is the common fox, and it is a very good to understand this difficult topic.
Yeah, it was made very simple, definitely interesting, and it will definitely help everyone in the day-to-day practice. And after hearing such a interesting IUI panel, which has simplified so many myths, your Locha, you have really mystified all the mysteries about all hormones so well. Very well spoken.
Thank you, ma'am. Yes.
Dr. Shivangi. And here I take the opportunity to wish all the contestants who are there for election all my best, all the best from NUGS Nagpur OBGYN Society to all of you.
Thank you, Pragati. Thank you.
Thank you. Thank you, Dr. Pragati. Thank you very much.
Yeah, I'm going to say something. Priya?
You're muted.
Yes, ma'am. Very nice talk by Dr. Shivangi. In infertility, we know 2 + 2 is not equal to 4 every time. And she is very well elaborated. We don't have to rely on the reports every time. We have to correlate the reports. Reading of report is very, very important. History taking and clinical diagnosis gives us a clue from where to start with, which investigation, which blood test we have to pick up the first. Like just thyroid and prolactin can give us the result. And then we can go upwards with the other hormones, because all the hormones are very costly. So clinical diagnosis and the history taking is very important to pick up that hormone. Very nice deliberation, Dr. Shivangi Bansati.
Thank you. Thank you.
Thank you, Shivani. Shivangi, you actually corrected our Lochai brain by your talk. Pragati, Priya, and Anuradha Madam, she's not seeing here. And I am handing over mic to Kalpana now for the second session.
Yes, thank you, Jyoti. Now, our next topic is first trimester anomaly scan. For this wonderful talk, I invite our chairpersons, Dr. Bharat Lanjiwar, who is a consultant having Test Tube Baby Center in Bandara, practicing for the past 35 years. Sir is the president of Bandara Uji Society and founder secretary too. Sir's interest is managing high-risk pregnancy, infertility, and also medical awareness program. Welcome, sir.
Thank you.
Our next chairperson is Dr. Kalpana Mangesh Kulbade, consultant obstetrician in Chandrapur. practicing for the past 22 years and secretary of Chandrapur Oji Society 2004 to 6. Now vice president of the same society, vice president of IMA also. She's into various organizations and special interest is high-risk pregnancy laparoscopy and hysteroscopy. Welcome, ma'am. Our next chairperson is Dr. Vaidehi Marathe, who is a director of Maher Maternity Nursing Home, Nagpur, almost for the past 27 years, winner of various awards, Signature Award twice, and also various Foxy Awards. Sadhana Desai.
Ma'am, we can cut this short. We are already running late, so we can straight away move on to the topic.
Yeah, very
Thank
few
you.
points. I will just.
That's okay. You can skip and we can proceed to the topic.
Yeah, it's a very long CV with various awards and various prestigious positions. Welcome, ma'am.
Thank you so much.
Over to you, chairpersons. Sir, Bharat sir, can you please introduce the speaker?
Yes, thank you, Dr. MC Patel, sir, and Happy Learning Series webinar, all organizers. Since the last 3 decades, the diagnostic capabilities of obstetric ultrasound has significantly increased thanks to technology and improved the understanding of fetal anatomy and physiology and anomalies. Hence, the shifting of the fetal anomaly scan to first trimester. That is the first milestone for screening the structural defects. So I call Dr. Mira, who is the first fetal medicine expert in Bandara. She is excellent in academics. She is very sober lady with hobby of the Kathak dance. So over to Dr. Mira for this anomaly first trimester.
Kalpana ma'am, do you want to give any introduction about the topic? Do we have?
I think Kalpana is not logged in, so we can move on to the
Yes,
topic. We request
yes,
Dr. Meena
ma'am.
to proceed
Yes.
with it.
Thank you, sir, for the introduction. And is my screen visible?
Yes, yes.
Am I audible clearly?
Yes, yes.
And is my pointer visible, the laser pointer?
Perfect.
Okay. Thank you very much. And a very good evening to all. And now that the Lochai hormones is resolved and the patient has conceived and reached the 12 to 13 week scan, I, the fetal medicine consultant, will do the first trimester anomaly scan. The first trimester anomaly scan as a term is anachronistic in itself, since now all ultrasound scans done at any trimester are effectively anomaly scans. And as we have to report any anomaly detected at any gestational age on any scan. We all know that the first trimester scan is used to screen for Down syndrome, where we measure the nuchal translucency and look for the nasal bone and other markers. It can be used to screen for preeclampsia, fetal growth restriction, and preterm birth. And we have this paper that says that 49% of major structural anomalies can be diagnosed in the first trimester. And the general axiom goes that more lethal anomalies are diagnosed earlier in gestation. Now, this is a pretty old paper. And now I believe relatively old, and I believe now that the number must be much more than 49% with better technology and newer guidelines. It goes without saying that a good first trimester scan needs a good machine, a good hand behind the machine, lots of patients for a good fetal position, and we get great results. Some of the patients I have included in this presentation are in the 14 to 17 week window who have missed the NT scan, but all those anomalies could very well be diagnosed at the NT duration. Please do remember that it is difficult to get great anatomical details before 12 weeks of gestation due to the relatively small size of the fetus. For best results, 13 weeks plus is preferable. I have referred to the recent 2023 guidelines on the performance of the first trimester scan, which outlines the bare minimum requirements for imaging the head, brain, neck, heart, abdomen, extremities, placenta, and biometry. These are what we see in general, but right now I'm not focusing on this because we all know this. and it has always been extensively covered in multiple webinars and lectures before. But what this talk aims to do is to inspire us to stretch our limits, and I'm standing on the shoulders of these giants who have lit the way forward for us. The guidelines say that these structures can be potentially, please mark my words, it can be potentially visualized. The list given in this paper, which is free to access, includes what we can see in the head, brain, face, neck, chest, heart, abdomen, spine, extremities, placenta, and membranes. This is how we measure the crown rump length, and in this image itself, many abnormalities can be seen, which include the always detectable 9. 3 in the head, acrania, cephalocele, and holoprosencephaly. Acrania looks like Mickey Mouse ears where the fetal head should have been. The brain lies outside the skull. A cephalocele can be seen as a defect in the skull with a knob where the defect is. A lobar holoprosencephaly is seen as an undivided brain with a dorsal cyst. Next, at the level of the neck, we can see iniencephaly, which leads to persistent neck retroflexion and a stargazing fetus, always looking fixed like this. The abdomen may show an omphalocele, which is bounded by peritoneal covering associated with aneuploidy. Gastroschisis, free-floating intestinal loops not associated with aneuploidy. Body stalk anomaly, where the umbilical cord is virtually non-existent. And megacystis with the bladder more than 7 millimeter in any diameter, which is associated with aneuploidy. In another plane, we may see limb reduction defects. These are very easily picked up in the first trimester as fetal movements are more free and the fetus is relatively smaller. These are the always detectable 9 abnormalities. In addition, many other anomalies can be potentially picked up. It may not be 100% detected and some may definitely be missed. That is why the first trimester scan can never replace subsequent scans. There are certain anomalies that can definitely not be detected at the first trimester scan. Progressive anomalies, some anomalies of the central nervous and cardiovascular systems, some skeletal and renal anomalies, gastrointestinal, cutaneous, genitourinary due to PCP&ET concerns in it especially, and any functional assessment cannot be done at the first trimester scan. I have some interesting cases which have been picked up over a 3-year period. This fetus has an increased NT, but that is not all. The fetus had A-wave reversal on ductus venosus and a normal appearing 4-chamber view. But the heart had only a single cardiac outflow. You can see there is a single cardiac outflow and it just goes all the way back. It goes without saying that such findings warrant fetal testing. However, this patient terminated her pregnancy elsewhere and now it is difficult to predict any recurrence risk. This is another fetus with a Grotz looking head. This is what the normal head should look like. The head is obviously anencephalic. But on looking further, the fetus also had kyphoscoliosis and some weird looking echogenicities in the gestational sac. So I went transvaginally and I saw the clinching diagnosis. These were amniotic bands and these bands were causing the fetus severe damage. Unlike anencephaly and open neural tube defects, amniotic band syndrome is not associated with any recurrence risk. Such patients usually give a history of PV bleeding very early in pregnancy, and amniotic bands can cause multiple defects in the fetus. This is another abnormal looking brain when we compare it to the normal. It was a case of A lobar holoprosencephaly, and the fetus also had other abnormalities like proptosis, low set years, midface hypoplasia. This fetus was more likely to be aneuploid, more specifically trisomy 13 or 18, and hence testing was recommended. In this fetus, the nuchal translucency, as you can see, was 7 millimeter, very large, along with fetal hydrops in the same fetus, tricuspid regurgitation, scalp edema, echogenic bowel, fluid in 2 cavities. You can see that the liver and lung outlines are very clearly seen because of fluid in the ascitic fluid and due to pleural effusion. This is a bilateral pleural effusion in the same patient, which was giving the lungs a bat wing shape. Hydrops can be due to chromosomal, metabolic, or cardiac defects. This particular fetus had trisomy 21. Hydrops can also be detected at an earlier gestational age. This is transabdominal and transvaginal scan of the same patient. And these are a series of fetuses before 11 weeks with nuchal edema, cystic hygroma, and generalized edema. The testing protocol remains the same. This is another fetus with an obvious bend in her spine, which we saw, which was more pronounced at the earlier scan. This fetus had a hemivertebra, which was seen on skeletal 3D imaging. The patient followed up in the mid-trimester. Now here you can see that the fetus has a slightly mild kyphoscoliosis, but when I counted the ribs were fewer in number. The patient surface rendering, the fetus surface rendering showed that the back looks relatively okay. Hemivertebra, if isolated, it has a good prognosis. And today the child is 8 months old and has no noticeable defect as reported by the parents. Another fetus that looks reasonably okay, the NT is good, the fetus profile looks okay. But what is not very obvious is this very small little skin tag below the nose. Also, the superimposed line sign, which has been described, which is the line of the palate above, line of the vomer above the palate. This is not seen in this fetus. This superimposed line sign is described by our very own Dr. Lakshmi Ravi Selvaraj. This fetus had a cleft lip and cleft palate. If you can see, the image is not very clear because the patient was obese, but you can see here there is a mild, small, very subtle cleft in the palate. And this is the 3D surface rendering of this fetus. You can see that this is not looking very normal. And when the patient was willing to continue the pregnancy, as her husband had a nephew who was operated for cleft lip and palate 20 years ago, and that boy is as normal as he gets. And this was the follow-up on the mid-trimester scan. Cleft lip and palate is definitely a treatable condition and it has very good results. Another fetus with an abnormal looking face, you can see that the mandible is back, and on the face image, you can see there is an absent mandibular gap. And the fetus on 3D surface rendering looked like this. And post-abortal, the picture looks exactly the same. In addition, post-abortally, what I couldn't pick up on the antenatal scan was the low set ears, along with a retrognathia, which is very typical of mandibular arch abnormality. Another case, this fetus had a unilateral kidney, contralateral kidney is absent. And you don't see a kidney on this side, you see a vertically oriented adrenal. This is the list of associated problems and we need to follow up on such patients till term, as the normal kidney, which can be seen, may also show changes which are compensatory or otherwise on subsequent scan. Coming to the heart, the cardiac axis has to be between 30 to 60 degrees with two parallel inflows, this and this, and two V-shaped outflows. It looks like this. This fetus had only one cardiac inflow. If you can see the stomach, the axis is okay, but the inflow, there is only one. There is a single inflow, the fetus mode, and the inflow is single, and two outflows. There are two outflows over here. Just a second. Yeah, there are two outflows. One is this, and the other one is the small little piece, which shows a reversal of flow. The flow is this way, that is why it is seen as blue on Doppler, and this flow is reversed, which is seen as red. So in this patient, it could have been either an atrioventricular septal defect, also called endocardial cushion defect, or it could be hypoplastic left heart syndrome. Atrioventricular septal defect is associated with aneuploidy, while hypoplastic left heart syndrome may not be associated with aneuploidy. It is always better to suggest fetal testing in such patients. Another fetus with a single inflow. And here, this time we see a distinct left inflow. The right inflow is closed. The tricuspid valve is atretic. And this is a video in which we have a very subtle blink and you miss it flow across the interventricular septum. As you can see, there is only a single inflow and a single outflow coming out. But when I looked further, there was a large left ventricular outflow and a very small, narrow pulmonary trunk, which showed reversal of flow. The flow is this way for the left ventricular outflow tract and this way for the pulmonary trunk. These are the outflows. It can be seen as blue because the fetal position is prone. So this was a case of tricuspid atresia with VSD. It has a guarded prognosis with the child requiring multiple staged surgeries. There is no known genetic association and hence probably no role of testing. This is another fetus with a reasonably good NT, good tricuspid Doppler, and good ductus venosus Doppler also. But the cardiac axis, if you see, this is the stomach and this is the heart, and the cardiac axis is almost 90 degrees. And the fetus had only a single appearing outflow. There is no V, as you can see. I gave a differential diagnosis of truncus arteriosus versus double outlet right ventricle. This patient was a case of conception following fertility treatment, and understandably, she was lost to follow-up. However, thanks to Dr. Gomkale, senior radiologist of Bandara, he did the mid-trimester scan and shared the follow-up that the patient was indeed a case of double outlet right ventricle. A single umbilical artery cord is very commonly diagnosed at first and second trimester scans when we find it. And we have to look for other anomalies, including cardiac, renal, etc. An isolated two-vessel cord has a good prognosis. However, we can counsel such patients regarding the possibility of intrauterine growth restriction. In this case, the fetus was otherwise normal and the patient delivered a 2.7 kg apparent normal baby at term. The next fetus has one hand and a part of the forearm absent. The other hand looks okay, but this hand is absent beyond the forearm. You can see that the hand and the fingers are not seen. This is a post-abortal picture. Credit to Dr. Nisha Bhavsar, senior obstetric gynecologist at Bandara. Similarly, this fetus had a leg that looked different. This leg looked okay, and this leg was persistently in this position. Multiple attempts to look at the leg were not very productive. It was looking like this. So I went transvaginally, and you can see that the leg was abnormally flexed and the foot was plantar flexed. And in multiple images, the fetus was showing the same orientation of the lower limb. And this is how post-abortally the fetus was looking at. You can see that the first leg was not moving and the second leg can move very freely. This is an interesting case. This fetus had an increased intracranial translucency. This is the intracranial translucency with a cyst in the posterior fossa. Can you see this? And it could have been Dandy-Walker syndrome or a Blake pouch cyst. The former has a very poor neurodevelopmental prognosis, while the latter is a transient finding. The patient followed up at the mid-trimester scan and the posterior fossa again showed a cyst with moderate Vermean rotation. This is the vermis. And a part of the cerebellum appeared missing. The lower part appeared missing. This is a 3D rendering of the cyst. This is the cyst, which can be seen on 3D. And this is what the normal cerebellum should look like. A proper vermis looks like this. Now, this patient was a case of recurrent pregnancy loss. And as with all good patients, she went for a second opinion. She was given a diagnosis of Dandy-Walker malformation and counsel for termination. We suggested that she go for clinical exome first before taking any drastic steps. And we got a variant of uncertain significance. Uncertain, why? Because this variant causes problems only in the homozygous state and the fetus was heterozygous for the condition. So we counsel the patient to be patient and follow up. Sure enough, at 26 weeks, the vermis started looking more and more normal. This is the 26-week picture. The cyst began to regress, and by the 9th month, the vermis looked almost normal. Now this child, post-delivery, the child is 6 months old and with milestones appropriate for age, and the child is starting to crawl. The devil is in the details with this statement. Structures that can potentially be visualized left open for interpretation. And as Dr. M.C. Patel sir can attest, we don't want to be part of any litigation. We can treat the newer guidelines either as millstones around our neck as an added burden, or we can use the new guidelines to motivate us and become better and better and to keep pushing our limits and become the best version of ourselves. Because we can diagnose something only if we know that it can be diagnosed. I thank my teachers who have always motivated me. Thanks also to the Bandara OBGY Society and the Vidarbha family for encouraging me. Special thanks to Dr. M.C. Patel sir and Dr. Sneha Bhoyar ma'am and the entire team of Happy Learning Masterclass for giving me this platform. And many more thanks to the audience for a patient hearing. And I hope I haven't left you all like this. Thank you.
Okay, so congratulations, doctor. You've done a great job. You deserve a big round of applause for delivering an exceptional and an informative talk on first trimester anomaly scans. Thank you for enlightening us and highlighting the importance of early prenatal care. The emphasis on early detection, the benefits of timely interventions, and the reassurance it brings not only to the families and to us as doctors was particularly enlightening. Dr. Mira, your passion for this subject was evident throughout this talk, and it undoubtedly ignited a shared enthusiasm amongst all of us to further advance and promote the importance of first trimester anomaly scans. You've rightly said your eyes can only see what your mind knows. So we really need to be aware of what we need to see. So thank you so much for this excellent deliberations. I would also like to thank Dr. MC Patel, sir, for inviting us here to chair this very important talk. Thank you. Thank you so much.
Thank you, ma'am. Thank you so much.
Yeah, it was an interesting and informative talk, and thank you, chairpersons, for your concluding remarks also. Shall I now request Jyoti to take over?
Yes. Thank you. Thank you, Vandana. And after an excellent talk by Dr. Shivangi and Dr. Meera, I would like to invite Dr. MC Patel for talk. And for his talk, our esteemed chairpersons are Dr. Shweta Manvatkar, Dr. Shweta Nitin Manvatkar, Madam, is MBBS DGO and the consulting gynecologist at Manvatkar Maternity and Nursing Home, Ballarpur District, Chandrapur. We welcome you, Madam. Our next chairperson is Dr. Varsha Dhavle, Madam. She is the past president of Nagpur Obs-Gynae Society for 2022 to 23, and she is the ex-state supervisory board member for PCPNDT government nominee. She is the past VP of IMA Maharashtra State in the 2015 to 16. She is past president of IMA Nagpur in 2013 to 14, and she has won many various awards like NOGS Gold Medal, Best President IMA National Award, Best Secretary of IMA Maharashtra State of Award, recipient of National Award of IMA Kanak Goal, Best Editor of Intimate Souvenir of IMA, and Best All-Female Team of IMA in 2013 to 14, and Chairman of PCPNDT Committee IMA Maharashtra State. Her area of special interest is USG and Obs-Gynae and Medical Legal Counseling. We welcome you, Varsha Dhavle, Madam. Our third chairperson is Dr. Sarla Agrawal, Madam, from the Bhandara Obs-Gynae Society. She is MBBS from MGI MS Sevagram and DGO from CPS Mumbai. She is the Obs-Gynae consultant and surgeon in Bhandara since 1987 and worked in Government Hospital Bhandara. She is the secretary of Bhandara Obs-Gynae Society in year 2007 to year 2008 and president of Bhandara Obs-Gynae Society in year 2016 to year 2018. We welcome you, Madam. I request Dr. Shweta, Madam, to introduce our speaker, Dr. MC Patel, sir. I request Varsha Dhavle, Madam, to introduce the topic. The topic is what constitute negligence in ART. And I request Dr. Sarla Agrawal, Madam, to conclude the topic. The CV is displayed. Dr. Shweta.
Thank you, ma'am. First of all, good evening, all respected seniors and colleagues. First of all, I would like to thank all organizers for giving me the opportunity for being the part of Happy Learning Masterclass 152 edition in association with Bhandara, Chandrapur and Nagpur Obs-Gynae Society. अब डरने की क्या बात है, हर हीरे को तराशने की कला उनमें खास है. अब डरने की क्या बात है, हर हीरे को तराशने की कला उनमें खास है. किस किस नाम से नवाजो उन्हें. The great leader, Bhishma Pitamaha, the legend, the man of vision, जोहरी रूपी आदरणीय डॉक्टर MC पटेल सर उनका नाम है. जो कहते हैं परों को खोल जमाना उड़ान देखता है, जो कहते हैं परों को खोल जमाना उड़ान देखता है. It's my great honor and pleasure to introduce our program director, respected Dr. MC Patel sir. He is a consultant obstetrician and gynecologist and medical legal counselor, Vice President FOXI 2018, Organizing Secretary AICOG 2017, Chairperson Ethics and Medical Legal Committee FOXI 2018 to 2013, Honorable Secretary State Organization of Gynecologists and Obstetrician of 2022 to 2024, Organizing Chairperson MMCon 2018, Honorable Member National Inspection and Monitoring Committee PNDT Act Government of India, Honorable Member State Supervisory Board PNDT Committee Gujarat State 2005 to 2009, President Ahmedabad Obs-Gynae Society 2010 to 11, Honorable Member, National Managing Body, Indian Red Cross Society Headquarters 2019, National President, National Medicals Organization 2016 to 2018, President IMA Ahmedabad Branch 2007 to 8, and Honorary Surgeon Indian Red Cross Eye Bank, collected more than 1,000 eye pairs. Organizing Chairperson Vivekanand NMO Con 2013, President Lions Club Ghatlodia, Ahmedabad, 1997 to 98. As the step ladder, like progress and success of Dr. MC Patel, sir, from 1997 till today. And I welcome and congratulate you, sir, and your team for such a wonderful academics, putting everyone under one umbrella with effective communication. Everyone so eager now to hear from you, sir. The very interesting topic, helpful in day-to-day medical practice, which play very vital role in the era of awareness. Sir, you are invited to shower your blessings. Thank you.
Thank you, Shweta madam. Yes, Varsha madam.
Okay, just few words from my side. Shweta madam ने तो बहुत अच्छा एकदम intro. It was really apt for an apt person, I should say. So we all know that he has a very strong team of medical legal experts, and MC Patel sir has always been the leader of this team. And I should say that I congratulate you, sir, for having such a beautiful web series. I remember last year when I was the president, we had one for Nagpur.
Yes.
And sir ka to haath koi pakdega nahi medical legal isme. So what I would like to just introduce the topic in short is we all know that medical negligence claims are do vary from different specialities. Actually, we know we like the medical and the legal committees, we both work diligently to avoid any malpractice and to zero down any of the medical legal cases which can occur. But as it is higher the skillful work and huge other finances which are involved, not forgetting the emotional attachment of becoming parents, you know, when it is infertility, when it is conception through ART, and when it is everything which involves, there's a lot of, you know, the family itself, the couple undergoes a lot of torment, torture, harassment, and then there are financial issues, of course, at the stamp of being an infertile person. So when this couple goes through all these, and this couple really wants to conceive through ART, but when some negligence or any malpractice in such a procedure is comes to fore, you know, like there's some mix up in the gametes or some embryo problem, some medication or some genetic defects are seen, or the surgical complications are there, improper consents are being taken, and some lab problems have occurred through which the couple has to go a lot of problem. And this is when the fury starts, right? The negligence starts. So here I am very sure that Patel sir will take us through a series of events in which how we can avoid negligence in throughout our practice, and how we can give our ART couples a beautiful baby and be transparent about everything, right? So over to you, Patel sir. We are just eager to listen to you. As always, we know that you have wonderful presentation, which is lively and which of course focuses on good take-home messages. So over to you, sir.
Thank you, Varsha madam, for opening remarks. Greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. ART, what constitutes negligence, is the today's topic for discussion. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank Nagpur, Chandrapur and Bandara OB/GYN Society and President and Secretary of respective society and all the delegates who have joined this webinar. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because medical litigations are increasing in number constantly and steadily, and unluckily we gynecologists rank first. And as far as this ART treatment is concerned, rightly mentioned by Dr. Varsha madam also, it attached with emotion and huge expense. And if we cannot give result, then it becomes an area for litigation in few of the cases. So what is negligence in this type of situation? So in our undergraduate curriculum in forensic medicine, we were taught two words: act of omission and act of commission. Act of omission means not to do something which a reasonable prudent doctor would do. Say, for example, giving a full dose of penicillin injection without negative test dose. And act of commission means doing something which a reasonable prudent doctor would not do. Say, for example, in a planned surgery, on full stomach giving general anesthesia. So these are some examples, act of omission and act of commission. But as far as ART treatment is concerned, how this act of omission or act of commission comes into picture, let us see one by one. So which are the ingredients of negligence? How negligence can be proved in court of law in any given situation? First is existence of legal duty. So as soon as any patient comes to you for any ART treatment, and if you accept to treat her, then it becomes a contract or implied contract between patient and yourself, and it is contract of personal services. You are giving your expert services, patient pays for that, or patient promises to pay for that. So as soon as you accept any patient to treat for ART treatment, your legal duty starts from acceptance of the patient at that very moment. Breach of that duty. So for any reason, if there is a breach in that duty to treat that patient as far as ART treatment is concerned, then it becomes one more ingredient as far as negligence is concerned. Damage suffered by patient. Due to this breach of your duty, if patient has suffered a damage could be physical, could be mental, could be financial, could be social. Say, for example, if patient suffers with ovarian hyperstimulation and some morbidity happens, then it becomes a ground for litigation. And very important point is doctor's conduct is direct and proximate cause of such damage. So these four ingredients: existence of legal duty, breach of that duty, damage suffered by patient, and doctor's conduct is direct and proximate cause of such damage are constituting negligence. It could be civil or it could be criminal also. But in our day-to-day ART practice, you may end up into litigation. Which are the common allegations in this situation? Delayed in diagnosis, investigation or treatment, missed diagnosis, investigation or treatment, wrong diagnosis, unnecessary investigations, no proper consent taken, staff not qualified, infrastructure issues, emergency services not rendered properly. If at all something goes wrong, some complications happens, and if emergency services are not provided, then also it becomes an area for litigation. Communication failure. If patient and patient party are not properly communicated which treatment plan you are going to go for, then also it may become area for litigation. Delayed in transfer. If at all any complication and if you refer patient to higher center, and if it is delayed in transfer, then also it becomes a area for litigation. Complications related to procedure and complication related to your treatment plan. Say, for example, if you have advised diagnostic laparoscopy and during that diagnostic laparoscopy some complications happens, then it becomes an area for litigation. Just like this. Say, for example, ovarian hyperstimulation syndrome, multiple gestation, fetal reduction and some complication related to fetal reduction, possibility of infection in procedure, possibility of hemorrhage, injury to surrounding structure at the time of retrieving ovum or at the time of any surgery related to enhancing surgery for infertility. Morbidity in very few cases, but if at all happens, maternal and or fetal, and mortality in very few cases, maternal and or fetal. These are some areas for litigation. Overcharging. We know as far as this ART treatment is concerned, it is expensive treatment. So tremendous expense against unexpected result is one more area for litigation. And ask for medical record and not provided. If patient or patient party has asked record of treatment given. And if you are not provided, then it becomes an area for litigation, because as per guideline from MCI, you are under obligation to provide record within 72 hours. And as per newer guideline for NMC, within 5 working days, you are under obligation to provide all the record of treatment given to that very patient. Failure of patient to comply with schedule follow. Many a time when you advise patient for certain follow-up and patient doesn't turn up, of course, it becomes a good defense in your favor, because it becomes contributory negligence on part of patient. But it should be mentioned in your case paper very meticulously, because it becomes a good defense. So in this type of situation, many a time, if you are not anticipated or not prepared to manage for certain complications, say for example, OHSS or any injury during surgery, then this question is usually asked, was it preventable? And if you usually you cannot say no. And if it is yes, then one more question, what did you do to prevent it? So not to end up into OHSS, which kind of protocol you should go with as per standard guideline by ICOG or FOXI or RCOG or so. So in this type of, if we have strictly followed a protocol and guideline from certain standard scientific norms, then it becomes a good defense in your favor. One more area, if you couldn't prevent, then why you couldn't prevent it will be one more area. Did you diagnose in time? If at all complications happen, then did you diagnose in time? And a very important question is asked, did you manage way in which any prudent doctor would have managed? So if you can answer all those questions, then you could be out of problem. Let us see a few of the case scenario related to ART practice. In this case, it was misleading advertisement in camp, no result, no money. Investigations and treatment started. Rupees 90,000 were collected. Later told that endometrium is not good enough for endometrial, embryo transfer, and cycle was cancelled. And hospital told the patient that there were few expenses as far as your treatment part is concerned. So deducting that amount, rest of the amount was refunded to the patient. But patient preferred case in court of law, and at the time of case judgment, inference held by the court was, though the center must have incurred cost in stimulation and pickup, but since it was promised that no result, no money, hospital is under obligation to refund all the amount. So it should be very clear with this case, carry home message, no guarantee as far as result is concerned. And if at all you are giving this type of guarantee that no result, no money, you should be mentally prepared to return all the money you have covered. Let us see this type of situation we come into our day-to-day ART practice. Many a time this type of advertisement, if first cycle fails, second cycle will be free. Is it ethical as per NMC guideline? So you cannot guarantee for result, but you can give this type of guarantee. If first cycle fails, we will go with second cycle free. And it is not non-ethical, neither non-legal also. It cannot be challenged in court of law also. But you cannot guarantee for result. And if you have given guarantee for result, and if you cannot give result, then it could be a troublesome for you. So in this type of situation, can one give guarantee? No, because in one of the cases, it happened in city of Mumbai only, guarantee was given and result couldn't be produced, case was filed and doctor was held responsible and medical council was informed by court, and medical council registration for 3 years was suspended of that particular doctor. So as far as guarantee part is concerned, we should be very careful at the time of counseling. Let us see few of the situation. अरे यार पैसे तो गोनेडोट्रोपिन में ही है, and IVF consultant sell gonadotropin for a profit margin is a very common practice in few of the centers, and it is a common allegation also. Is it allowed? A very important question. under pretext that I am using for my own patient. So yes, use versus sale of drugs and under drug control office. So it is very clear. Doctor can legally dispense medicine to his or her own patient. No separate license for this is required. Doctor can also give the medicine or injection to his professional colleague also. So it is dispensing, not selling, only to his patient or other doctors as per Schedule C biological and special products are concerned. Cannot open shop or cannot import drugs. He cannot sell drug to patient who have prescription of other doctors. So in this situation, you may be in a trouble. If at all you want to sell, then separate license should be taken and separate shop can be done. So in this type of situation, if you have no license of selling the drugs, you cannot sell drugs. It should be very clear. Have to keep record. Even if you are dispensing in your own patient, then also as per standard guideline, there is prescribed register, that is register K. And in that K register, you have to mention how much drug you have purchased with expiry date and batch number, and that very drug in which patient, in how much quantity you dispense or utilize. So that way you have to maintain register as far as this dispensing of medicine is concerned. Let us see one more scenario. In this very case, ICSI with sperm derived from testicular biopsy for a couple with a male factor, that is azoospermia. Husband was azoospermic, so ICSI was decided and testicular biopsy and sperm was retrieved. And in this case, patient was having PCOS also with multiple fibroid, and 2 trials were failed and they were succeeded in 3rd cycle. So Progevinova and natural progesterone prescribed for support, and there was allegation on part of patient that she was advised complete bed rest by doctor, but it was denied in court of law by doctor because this patient suffered pulmonary embolism. There was thromboembolic phenomena and there was pulmonary embolism, and allegation on part of patient was, I was advised complete bed rest, which led to thromboembolic phenomena and I suffered pulmonary embolism. So we should be very careful in this type of situation. Let us see one more situation. ART done and donor gametes used, is it adultery? So in ART Act, it is very clear. If it is in ART done by donor gamete and proper consent is taken, then it is not adultery. So proper consent is very much required in this type of situation, particularly in artificial insemination by husband or by donor. There should be specific consent, and how consent should be taken, there are prescribed form also. As far as artificial insemination with donor is concerned, without husband's consent, can it be ground for divorce or judicial separation? So if without knowledge of husband, if AID is done, then it becomes a ground for divorce or judicial separation. So this type of practice we should not entertain in any situation. As far as AIH is concerned, in this situation, say for example, husband never had intercourse willfully or due to impotency. And in this case, again, sperm retrieval was done from testicular biopsy and pregnancy occurred. So is it considered as a consummation of marriage? And can decree of nullity be granted in favor of wife for divorce under impotency? So again, it is not consummated because in this, there was no intercourse. Testicular biopsy, retrieval of sperm and pregnancy happened. So this was the ground for judicial separation, and decree of nullity was possible in this type of situation. So whenever we are indulging this type of practice, we should be very careful at the time of taking consent of patient in this type of situation. Indian Evidence Act, child born with 280 days of dissolution of marriage or death of husband or divorce is considered a legitimate child. But if it is more than 280 days, then it is illegitimate. But one condition is there, but it was from stored sperm of husband, then this will not apply. So it should be very clear. Let us see one more situation. What happens if DNA of baby doesn't match with genetic parents? In other words, we can say lab mix-up. What happens? In this type of situation, it becomes a very difficult situation for any bank or any clinic to face in court of law. So, which are the some situation again? The DNA of surrogate baby doesn't match with genetic parents. Is the commissioning couple or parents still bound to accept the baby? So there are some legal issues. So in this situation, there should be barcode system. The barcode which is given to the patient in patient's file, the same barcode system should be on the sample. And when this barcode code matches, then only then sample can be opened. Then this type of mismatch can be avoided. And it is expected from law also. Death of an egg donor. What is the medical legal scenario? In this type of situation, how you have selected egg donor, whether egg donor was properly screened, properly managed as far as treatment part is concerned, what was the cause of death, all the points are taken into consideration. So we should be very careful at the time of selecting egg donor also. What is the role of ART bank in such situation? Just I mentioned, bank is under obligation to screen properly, and patient should be eligible for egg donor legally and physically and medically also. Is it legally correct if wife without husband's knowledge request for egg donation? Is it legally correct to use donor sperm with only husband's consent without wife's knowledge or vice versa? All these conditions we should not entertain, because legally, if at all it is proved in court of law, it becomes very difficult for ART clinic or ART bank to face in court of law. And ART Act is very stringent as far as punishment part is concerned. So never indulge in this type of practice. Let us see one more interesting situation. Embryo developed, but before transfer, death of husband. Can wife use this embryo? Today only the same situation happened in city of Ahmedabad, and there was a phone call from ART center. Sir, this has happened, and now wife is ready to get embryo transferred. Can we do? So in this situation, at the time of taking consent, it should be very clear that in case of unforeseen condition, in case of death of husband, if a consent is given that wife can utilize embryo, then wife can very well utilize their embryo. Same way, if death of wife, then can husband use in her friend or second wife in second marriage? Again, same will be applicable. What you have taken at the time of taking consent. So if consent is given by wife that in unforeseen condition or in event of my death, my husband is free to use in her second wife or in her friend, then he can very well utilize. One more area, death of both. Embryo is developed before transfer, death of both, husband and wife both. Then in this situation, can father of husband claim embryo? One more question, can father of wife claim embryo? Again, we will have to refer consent. So if in consent, if specifically mentioned like this, then any party, father of husband or father of wife, can claim embryo. So at the time of taking a consent, we should be very clear. Let us say one more interesting case scenario. In this case, it happened in city of Visakhapatnam. So this couple, Yugandhar and Ekta, married for 12 years without any child. And after coming across advertisement by this ART clinic, they went to doctor. Doctor suggested to have child through surrogacy. But surprisingly, they were agreed to pay rupees 15 lakhs for this whole process to have baby. But surprisingly, this ART clinic had a condition with this couple that we will not make a visit or counseling of surrogate mother with you. So surrogate mother was not met this couple. They paid 2 lakhs in advance at the time of beginning the treatment, and rest of the amount was to be paid when surrogate mother becomes pregnant and when she reaches 20 weeks of pregnancy. Surrogate mother was not shown to them as promised. They were told that surrogate mother will give birth to baby in August 2020. However, in July 2020, both the 2 doctors and 6 other persons were arrested by police of Visakhapatnam with the charge of child trafficking in this type of situation. So what they were practicing in this situation, trafficking any child, they had a plan to give that child to this couple against rupees 15 lakhs. And in this case was filed and doctor was released on bail. Clinic was again open, and that couple reached to that clinic and asked for money to be refunded, all 15 lakhs. But this clinic didn't refund it. So they preferred appeal in consumer forum, and fertility center was sealed after child trafficking incidents because health minister of that state ordered to seal this ART clinic. But in due course, from court, they could manage bail, etc. And this hospital was reopened again. But couple repeatedly visited hospital to return money, but they were denied to give money back, giving one or other reason. So in this case, when case was filed in consumer forum, judgment came to return rupees 15 lakhs, compensation of rupees 1 lakhs, and legal expense rupees 10,000 was to be paid to that couple. So with this case, it should be very clear. We should be in a very ethical practice. No such type of practice should be entertained because these are very dangerous practice and there are very stringent punishment as far as this type of practice is concerned, as far as ART practice is concerned. Let us see one more case scenario, which is also real happened case in state of Tamil Nadu. Girls visit ART bank with her mother to volunteer for ovum donation. So, as far as ovum donation part is concerned, ART bank is under obligation to screen, to advise certain tests related to this STD, etc., HIV, HBsAg, SCV, then VDRL, and general investigation also. And ART bank is under obligation to confirm age of the patient also. But in this situation, they gave Aadhaar card, and Aadhaar card was verified by ART clinic, and she was screened for as per ART Act, and all the reports were normal, and she was subjected for ovum donation. But after some time, police visited hospital and arrested both the doctors because patient was minor, and the Aadhaar card which was given to the doctor was fake Aadhaar card. And in this case also, health minister again ordered to seal all the clinics which were involved in this era, and almost 4 clinics were sealed. Of course, in due course, they could manage in a court of law, and stay is granted, and all the clinics are open. But one of the 2 our gynecologists which were very innocent, because this Aadhaar card was fake, it was not to the knowledge of them, when Aadhaar card was produced, they saw, yes, she is major, and straightway they plan for ovum donation. So both the innocent doctor, they approach me. I have guided them how to get rid of this problem. But these are the certain conditions we should be very careful. Even if Aadhaar card is given, now there is a possibility to check on net also with Aadhaar card number, whether it is regular or whether it is fake. So we should be very careful as far as this type of problem is concerned. So this is the whole story of this very hospital. So we should be very careful in this type of situation. Let us see a few of the situation, very interesting situation in our day-to-day, our ART practice. As far as oocyte and sperm donation are concerned, so point as per ART Act, any woman, here word any woman is used, irrespective of her marital status, but age is very specified. More than 23 years and less than 35 years can be a ovum donation subject, irrespective of her marital status and or history of pregnancy. Need not she should be pregnant in past or she should have child, and or motherhood. Proven fertility is not mandatory by said act, but preferred clinically, can become oocyte donor. So unmarried, if she is eligible by age and by all the tests, and if it is married, then if she is by age and all other criteria. But when she is married, then consent of husband is very much required for ovum donation program, and she should be from STD and genetic diseases, and she should be medically fit. So it should be very clear as far as ovum donor are concerned. Bank shall not supply sperm or ovum of a single donor to more than one commissioning couple. So bank will supply sample to one commissioning couple only, and oocyte donor shall donate oocyte only once in her life, and not more than 7 oocytes shall be retrieved from oocyte donor. But in this, here mention is 7 oocyte. So you will have to go for retrieval of all the cyst, because if you leave oocyte inside more than 7, then she may become a victim of OHSS. So you have to retrieve all, but you can utilize only 7 was the interpretation given by government in one of the question when it was asked. And patient should be free from STD and genetic disease also, and she should be medically fit. Let us see few of the situation and explanation as far as this ovum and sperm donation is concerned. ART bank can supply donated sperm of a particular sperm donor only once to a particular ART clinic, level 1 or level 2, for a particular patient. Here word is very useful, because in any law, you have to interpret word used for that very section or that very rule or regulation, because law is a jugglery of word only. So in this, very specifically mentioned a particular ART clinic and for particular patient, but nowhere it is mentioned whether male can donate only once in a life. So this is interpretation. So there is a possibility of interpretation in such way that one sperm donor sample may be supplied to a single clinic for single patient, and for as many times as required if pregnancy doesn't take place to that particular couple, if that couple wants to use that sperm donor sample only, but can be supplied to other ART clinic for other couple. So this is interpretation as far as jugglery of word is concerned. Let us see very few interesting situation very quickly. Can an egg donor bank supply egg donor to clinics located in different state? Yes, because as far as this ART clinic act is concerned, ART bank can supply ovum in other district also. Can woman unrelated to commissioning couple, be a surrogate mother. So previously it was mentioned that surrogate mother should be blood related, but now it is changed, relative or any interesting person. So now again it is yes. Can an unmarried woman donate eggs? Yes, if she is fit age-wise and medically and with all tests, then she can donate. Can an unmarried man donate sperm? Yes. Can an egg donor bank be run by an educational or charitable trust, or say for example non-medical person? Yes. But he or any educational or charitable trust or any person who wants to go for egg donor bank, then he will have to give all the information about the person who are going to work in that bank with all their requisite designation and experience certificate, etc. And if all the persons going to work in that bank are eligible for work, then this type of license can be given to other persons or other institutions also. Can an egg donor bank supply frozen eggs to the clinic? No, because as far as ART bank's definition is concerned, in this ART Act, organization responsible for collection of gametes, storage of gametes and embryos, and supply of sperm, semen, oocyte donors and surrogate mothers to ART clinics or their patient. Here it is not mentioned that they can supply embryo to the ART clinic. So can egg donor bank stimulate egg donor or conduct egg retrieval process? No, because only ART clinic is given power in this type of situation. Can egg donor bank advertise for recruiting egg donor? Yes, they can give advertisement also in newspaper also for inviting eligible egg donor. Can egg donor bank collect semen sample from level 1, level 2 clinics? Yes, ART bank can collect semen sample from anywhere, but collected sample or from whom they are collecting, that person should be eligible for sperm donation. Can egg donor bank supply stimulated donor to level 2 clinic? No. So stimulation should be done by ART clinic only. So what to do or how to prevent not to end up into this type of litigation? So it is very clear, no ART clinic, bank or surrogacy center can function without registration. So registration is very much mandatory and it is very obvious. And we should anticipate or foresee certain complications related to our treatment plan, because law and act expect from us to anticipate certain complications. Say, for example, just I mentioned for OHSS. So we should plan our treatment in such a way not to end up into any complication. And if at all any complication is anticipated, then we should be readily available to deal with the situation in this type of situation. But proper counseling is very much important. And whenever you counsel patient, we should explain everything in detail about our treatment plan as far as ART practice is concerned, with all its possible complications, with success rate in your clinic, success rate in your area, success rate in your district, success rate in your state. No rosy picture about result, no tall claim in ART practice, because in eye of law, when you claim to be master, you are supposed to be master. And in our practice, many a time we may consider result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture in this type of situation. So proper communication, proper documentation, because in this famous case, C. Jaipal Reddy versus Padmini Veluri, in National Commission, it was very specifically mentioned that consent is not mere piece of paper where patient or patient party has to sign, but it is a very important document of your communication. Whatever you have counseled, whatever you have communicated, Each and every point should be mentioned in consent paper. And when patient and patient party signs the document, it becomes a documentation of your communication. So whatever you have communicated, whatever you have counseled to the patient, it is documentation. And once you offer all those documents in court of law, it becomes a communication of your documentation. But records are always at your rescue. So keep them up to date. What was done, nothing was neglected. Given treatment fully met with standard demanded by law and ethics. Both way we should be in a position to prove it was ethical and it was lawful. It should be easily acceptable whenever offered in the court. And these are the long list of all the forms we have to observe, but I do not want to go into detail. It is available on website, but I would like to mention this in particular. These are certain register you will have to operate, and for that there is a form 14. It is prescribed form. 14A is for oocyte donor, and all the details in that form is given. So you have to prepare register for that. Name of donor with its address, age, and how many oocyte you recovered, and utilize on which date you recovered, stored, then embryo developed, then in which patient you have utilized. That way, all the columns are there in that register. 14B is the register for oocyte and embryo record. 14A is simply oocyte, and 14B is oocyte and embryo record. Form 15 is consent form for donor of sperm. So these are all the important forms you have to observe in your practice. But your patient and patient party, so all the party involved in ART treatment should be well informed. Are your patient properly informed is the question many a time asked whenever you are facing litigation. And doctor is bound to produce record whenever asked by the court. And if he doesn't, then adverse inference might be drawn. And it is very obvious, good record is good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice. We doctors' friends are very poor as far as record keeping is concerned. So to conclude with carry home message, we have to strictly follow standard protocols by ICOG or FOXI or RCOG or ISAR. So if we have followed standard protocols, then we are saved in court of law. Adequate supervision and monitoring throughout the whole procedure, communication, counseling, and proper consent, documentation and proper record keeping, foreseeability and anticipation or certain complication, and we should be readily available to deal with the situation. Multi-specialty approach. If at all we need to involve our senior colleague, do not hesitate to involve them. Please involve, because it shows your concern to take utmost care of your patient and to take care in your treatment plan. Prompt diagnosis with necessary investigation in case of any complication. Qualified anesthesiologist, an audit of your own case if at all something has gone wrong, not to repeat this type of situation in future. But this gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So there are so many provisions in ART Act also in your favor. But if you do not know, then it won't be useful. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So if you want to sleep like this, take tender care of your patient, strictly follow provisions of ART Act and rules and regulation, pray your Almighty God before going to sleep, and keep my visiting card below your pillow. And this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful in any given situation. So please do not hesitate to have a phone call to medical legal expert in any given situation. He will be useful in that given situation. So God bless you. Have a litigation-free practice. With regards, salute to all the societies who have joined this webinar, President, Secretary, and all the delegates. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much.
Sarla Madam, unmute yourself. Sarla Madam. Sarla Madam, unmute yourself.
If she is not there, then rest of the two chairperson can.
I think she is not audible. Sarla ma'am, you're not audible.
I think Sarla madam.
Till the time she.
Yes, Varsha madam.
I think I should really congratulate sir and thank you for his wonderful presentation. It was as usual. We had expected the same. Different situations, wonderful situations, and a wonderful advice. I know that ART Act is still in the. There are a few loopholes.
Yes, some confusions also.
Yes. We know that it is not in its completion stage, and a few loopholes that we can still use for our advantage, and probably we can make best out of it. But then, yes, of course, the transparency lies in telling everything which is truthful, being very transparent, taking good consent, informing the couples about everything, and that is how you can save your skin all the time, every time. And then yes, आपका काम कम पड़ेगा sir.
Particularly in case of any complication, post-treatment counseling is equally important.
Yes.
For example, if OHS has happened, or during fetal reduction some complications happened. So this type of situation, if we counsel patient and patient party, actually what has happened, what we have done, what is the probable prognosis, then patient and patient party are many a time they are forgiving.
Yes.
In all the situation, they are not stringent one to go for litigation only, but proper counseling is very much important.
Yes. Recently, there was a judgment in which one of the corporate hospitals, the couple, the child was born through ART, and then there's something happened in the blood group. I mean, the blood group didn't match both the parents, and that is why I think it was a huge consumer claim on the hospital, and the hospital had to pay. So such things do come across.
But in this type of situation, DNA testing, etc., are advised in court of law. And if it is proved, then it becomes very difficult for any ART clinic or bank to face in court of law.
Yes. True.
So what is the role of insurance of donor and acceptor? And second is, what is the, is there any incentives related to surrogacy?
So as far as the insurance part is concerned, now it is compulsory. And not only compulsory, but it should be from recognized insurance company, which are recognized by government. And as far as surrogate part is concerned, the same insurance part, whenever you go with insurance for surrogate mother for 3 years, and it should be attested in court of law that you have taken insurance for the same, and you will have to go for affidavit in court of law that on part of commissioning couple that they will take custody of baby delivered by surrogate mother irrespective of any condition. So commissioning couple will have to give this type of affidavit in court of law, and then only surrogacy program will be allowed. So now in this newer ART amendment, it is very clear as far as insurance and as far as this custody of baby is concerned. For this donor, for 1 year, for surrogacy it is for 3 years. But if at all, if any complications happens due to that procedure, and if it is proved, then till that complication is cured, commissioning couple is under obligation to bear expense of the ovum donor or surrogate mother. irrespective of time.
I think that was clear enough. Anybody has any more questions for sir? Before we just wind up with the...
Oh yes, oh yes. Yes, coordinator Jyoti, Kalpana, you can proceed accordingly.
Sir, Kalpana is going to give vote of thanks. Sir.
Oh yes.
Kalpana? Kalpana, unmute.
First of all, I would like to thank MC Patel sir for organizing 152nd edition of Happy Learning Series. That too nowadays, all Tuesdays and Thursdays we have, because of persistent work, we have been able to do all these webinars. I should thank MC sir, Program Director, for this. And also Sneha Goya ma'am, who is the convener of this series, and madam couldn't be here because she has got so many webinars in addition to this. I should thank all the chief guests and seniors, Sulabha ma'am, Raj Lakshmi ma'am and Lakshmi Shrikante ma'am, who had given blessings and encouragement for us, and all the society president and secretaries of Bandara, Chandrapur and Nagpur, and all other experts from these societies for joining in this webinar and making this webinar a successful one and wonderful talk. Initially in the panel discussion was the stories were too good, and I thank moderators Manisha ma'am and Sushma ma'am for the wonderful cases, and also expert comments by Rekha, and also panelists were also very interactive. I thank all the panelists, Dr. Bharati, Dr. Prajakta, Dr. Manisha, Dr. Manoj, Dr. Meenal, Dr. Sharmili, Dr. Chaitanya, Dr. Meenal, Dr. Anjali for very good interaction, and the speakers were too good. Dr. Shivangi, Dr. Meera, and also MC Patel sir's talk was very informative, and even now all fertility consultants are having so many doubts because the law is not very clear as far as ART bill is concerned. So we do have many doubts. If at all, if we have any doubts, we can contact MC sir for his guidance, I think. And I also thank all the chairpersons, Dr. Pragati, Dr. Priya, Dr. Anuradha, Dr. Vaidehi, Dr. Kalpana, Dr. Bharat sir, and Dr. Shweta, Dr. Varsha, and Dr. Sarla for wonderful interactions, and it was quite interesting. And also I thank our academic partner, Corona Remedies, who had been associated with us continuously over these years. Finally, I also thank the delegates who had been with us in large numbers, even at 9:30 p.m. Once again, I thank MC sir and other coordinators and conveners.
So thank you all for participating in this webinar 152. So if
thank you, Varsha. Thank you, Manu sir. So just because of you, we can connect to each other with a very
yes.
It is very
giving us this platform, wonderful platform, very encouraging. Thank you, sir.
So thank you all.
So good.
Yes, so,
Madam and
should we conclude then?
Sir, your talk was wonderful because it included many practical points, especially the case scenarios.
Yes.
Though we have heard many times, but this
that very case which happened with that our two gynecology.
Real cases, no? All were real
cases. Yes, that way.
Yes, all were real cases,
Yes,
and for us,
she was minor, and both of them from Erode only. And in Osur conference, they both met me. Before that, they had consulted me. I am guiding them how to get rid of this problem, because they were very innocent. They believed that Aadhaar card which was produced. They never doubted, and from look, that girl was looking just like 20 years or so. So they didn't doubt also. Otherwise, if at all there is a little doubt, then one can go for verification of Aadhaar card.
Sir, but then what is our stand in saying? Like, people come give you the Aadhaar card. How
Aadhaar card, you can verify Aadhaar card on net also. Now,
yeah,
on net you can verify.
Putting down the numbers, you can get the
You can verify. Because so many ART clinic, I can say in Gujarat, because we have already advised them, they have make a habit. Whenever Aadhaar card is produced, then they verify that Aadhaar card and then only they will proceed in further program.
Okay.
So on first consulting, it's fine. And their staff are trained how to check that whether this card is regular or it is fake.
Hotels में करते हैं ना sir. Hotels में also they check.
Yes.
So when we are in doubt, we have to do that.
Yes, naturally.
Cleanly.
I would say not in doubt in each and every.
Always.
How
like
can
some
we
patients-
say?
Is there
No,
a
sir,
particular
like some-
site wherein we have to put this, or how do we verify them?
There is a site actually, Varsha.
Ha.
The government of India actually here also MC sir was here also one girl. That girl is underage and I don't know, someone in the village triggered her, and she went to the 3 ART clinics in Indore, and with the different Aadhaar cards, one for herself, her mother's, her Mausika, and just to gain money. And there is a group of all the ISAR person in the Indore, and the one person is having the doubt, so she put the photograph and Aadhaar card of that girl in the other center. Then they picked the girl, and the police case was filed actually.
Those people who have prepared the Aadhaar card should be punished than the doctors, no sir?
So in this type of situation, whenever this type of cases happen and FIR launched, then police takes all the steps against all those persons who did this fake card, who supplied this fake card, and then a whole chain will be trapped.
And that girl, she was saying in the police station, she donated egg previous months, 3 months back also. So when she was trying to trap the infertility center also, but all the 4 infertility center, they are so united, and they went to the police station and they told that girl is producing the fake Aadhaar card, and what is the fault of the doctor when the girl is.
Yes, true.
So in short, we should be vigilant in our practice, because as far as this Aadhaar card part is concerned, other than ART, say for example, any girl comes to you for termination of pregnancy, and in this type of situation, if at all she is minor, of course your center is registered, you are qualified, you can terminate, but you will have to inform police. And if you have not informed police, and police will come to you when she was minor, why you didn't inform police? So in this type of situation, we should be very careful, very vigilant as far as verification of Aadhaar card is concerned.
सर आपका वो जो आइज वाला आता है ना सबसे एंड में, जो
डर लगता है वो आइस देखे तो हमें ही देखते हुए
देखने का
Sir, one thing.
Thank you, sir.
Yes.
I want
one thing before
Manoj Agyave sir and
Jyoti, 1 minute.
Jyoti, somebody wanted, yes, Bharti, yes, Rekha.
Yeah. Sir, you said that we should check the Aadhaar card of everybody, but we are sure, like the person looks more than 30 and all that, we can make out by face and all that. No, sir?
It's fine. This is particularly for vulnerable age group. So
that's what, doubtful.
18, 19, 20. Otherwise, more than 30, if you can make out from face,
exactly.
It's fine.
That's what. That was my doubt.
Yes.
Fine. ठीक है, thank you.
I was just saying, sir, मेरे को मनोज अग्लवे सर को फोन लगाना मेरे को आज अच्छा हुआ कि मिल गए सर सामने, so I can make a appeal to Manoj sir.
Jyoti.
Varsha ma'am, you know,
All the best.
you know, Varsha madam, what we are going through, you know very well.
Yes.
You know, all the society.
I admire and appreciate.
Chandrapur, Mandara and Nagpur, they will support candidature of all the contestants, Dr. Kalpana, Dr. Suman, Dr. Jyoti and Dr. Bharti. And of course, Sneha.
Yes.
Yeah, sure.
Because you are eligible candidate, you are hardworking persons. And I can endorse. Why? Because since more than 1 year you are with me in this series. So I have seen you working. So that is why I can say you are a hardworking person.
Actually, sir, what happens in morning, we are also having some operative and OPD works, and by the time we try to call some president and secretary, they are also having lot of work, so they are also not in the position to receive the calls. Actually, the
best time to call around 1 p.m.
Yes.
Comparatively, they are becoming free. And in the evening after 7 or up to
8 p.m.
8 p.m. Because usually I call anybody 1 p.m. or 8 p.m. and usually I get answer. Usually.
Even at the tea time, 8 o'clock you can.
So
8
there
o'clock.
will be one more reason. My number would be there with
Yeah.
them. So that also they will respond.
And not on Sundays, probably. They don't like. Sundays or never.
Because
They
for
will kill us.
any webinar,
They will not
for any
like.
webinar, at least I have to contact more than 30 people. Then only one webinar is designed. So to contact 30 people and few of they will say they are not available that day. Then again, I will have to go to contact one more. So almost 30 to 35 people I have to contact. Then only one webinar happens.
Sir, actually, we are so lucky to have with you. Actually, you have given a so good platform for all the academics thing. It's not for the election, but this
We are also with
Other
you.
than election is the one part, but other than election,
This is
by
the best
month of August, we will be completing our third round. So 266 societies of Foxy, we have visited all the society thrice with this platform. So it is very important thing.
Sir, another thing is, as I'm associated with you since such a long time, and because you have made me as expert panelist in almost all of them, it has become so compulsory for me to read each and everything like a student. As a PG student, every time I read and all that.
Usually we try to involve, say for example, today 3 society. So faculties would be from those society only. The speaker, moderator, panelists, chairpersons, except our team. Our team is there to assist them. But otherwise, so we give platform to each and every society, even smaller society, we have given platform. So many times this is appreciated from very small society. They appreciate that you are giving good platform to because there are so many hidden talent in our Foxian friends in smaller society also. And so our rightly mentioned by somebody as a Johari to me. So I am doing that work only. Hira Taras. So
but I'm very sure that I'm very sure that nobody covers 3 rounds completely the Foxy. I'm very sure nobody can do that Herculean task.
See, Varsha, your husband is coming for.
That's right.
So now we should conclude.
Bye bye. All the best, everyone. Thank you.
Corona friend is also waiting. So we should conclude. Yes. And we are very thankful to Corona people also.
Yes.
But they are also supportive in our academic activity.
Thank you, Piyush sir. Thank you. And Shweta, your shairi about for sir is excellent. Shweta, thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Good
All
night.
the best.
Thank you, Piyush.
Thank you. Good night, everyone. Pranam, Shah. Namaskar.
Yes, we can conclude.
Yes. By next Tuesday, probably your main part of the election is over, no? Next Tuesday.
No, election is from 1st of August to 10th of August.
Now today is what? Today is 20th. Okay, fine.
So our next webinar is on 25th.
Yes.
And then 1st of August, 3rd of August, and 8th of August. So by that time, election will be running. So by 10th of August, it will be over. But after that, election of chairpersons. So other than Sneha, all the contesting for chairperson they will be on toes.
Good night.
Okay, sir. Good night. Bye.
Yes, we can continue.